Okay, good morning, everyone, and welcome back to the HSMA programme after our extended Christmas break. So hopefully you've all had a nice rest over Christmas. But now we're back into the second half of the training phase. And just before I go on, just hopefully you've all seen the message I posted yesterday on the Slack channel about my surgery and about what we're going to do about that. Apologies for the slight disruption that's going to cause. Hopefully you shouldn't notice too much disruption. The main thing I would flag up is it's very clear, those of you who went to the revision sessions, that Elliot is an excellent teacher, but he has not delivered these sessions before, and delivering these sessions on your own is quite a task. So first of all, my huge grateful thanks to Elliot for agreeing to do that on his own while I'm not here, but also go easy on him. So he may not have all the answers. If it helps, I know nothing about geopandas, so I wouldn't have had the answers either if I was here. But just bear with him, and obviously if there is anything, if you do have any questions, obviously do ask questions, but he may need to get back to you after we've spoken to other people, so please do bear with us. But hopefully we'll still be able to keep the HSMA fires burning, as it were. So today, before Christmas, we explored a little bit of agent-based simulation around the issues of my boiler going wrong. I've now got a nice new boiler, and it's nice and warm, which is excellent. But we looked at agent-based simulation, and we talked about how, when we first looked at discrete event simulation right back near the start of the training, we said that it's a way in which we model systems that are kind of queuing-based systems that we can express as a queuing-based system. So they're very often used to model pathways within services, with people sort of coming through, and that doesn't have to be people, but very often is queuing for various resources, and then they move on to something else happening to them which requires a resource, etc. And so they're very useful for modeling what if scenarios in those kind of systems. But the kind of classic trio of operational research approaches, and there are many, but the classic trio is discrete event simulation, agent-based simulation, and system dynamics. And so we looked at agent-based simulation. We said agent-based simulation is kind of where you zoom right in. It's all about a queuing problem. You're modeling your system where you're saying, well, essentially my system is made up of all of these individuals who are all behaving in some way, and because of that, some system level, population level dynamics emerge. But we essentially model lots of little actors within our system who are behaving in a certain way and interacting with each other and with their environment in a certain way, and that causes the kind of population level dynamics to emerge. System dynamics is kind of the opposite of that. It's where we zoom right out instead of zooming right in. So instead, with system dynamics, we're looking at the whole system and looking at the structure of the system itself. Okay, so it's a really zoomed out, high level view of a system. Now, in this module, we're going to be looking at a couple of different approaches to modeling whole systems, one of which is system dynamics, and the other is network analysis. And so most of this module is going to be looking at network analysis, which is a big thing that we do within the team that Sean, our colleague Sean's got a lot of experience in, and Elliot's going to be taking you through all of the network analysis stuff. And network analysis basically uses graph theory and is a fantastic way to try and unpick very large scale complex systems, which anyone working in the NHS will know sounds familiar, and they can be really useful for that kind of thing. But there is this thing called system dynamics as well, so we're going to show you a little bit of this in our first session of module 4, which of course is 4B, because in HSMA the conventional rules of mathematics go out the window, and we start with session 4B, and then we do 4A in a few weeks time. So there you go. But today we're going to be using a piece of software called InsightMaker, which is one of the few instances of things that we're going to show you that don't require any coding. it's a drag and drop. So those of you who are just need a bit of a break from Python, or perhaps you're finding Python maybe isn't quite for you, this is an alternative approach. It doesn't really require any coding. You put in some simple equations, very simple equations, but it's largely a sort of drag and drop interface. But it is, of course, a free and open source piece of software, because that's all we demonstrate on this course. So let's talk a little bit about system dynamics. So system dynamics is basically a modeling method in which the structure of the system, and by that I mean the way in which the various components of a system are arranged and how they relate to each other, are captured. And a fundamental principle of system dynamics is that structure determines behavior. It's the way in which a system is set up that is the interesting bit that you are trying to capture. And basically you kind of use system dynamics to try and say, look, is there a fundamental problem in the way in which this system is structured? Is that what our issue is? As we'll see, it might be that there's something about the way your system is structured that is causing a positive effect in part of it, and you want to do more of that. But there's something about the way in which the system itself is structured, without getting down to the how individuals are behaving as we would an agent-based simulation, or how people are going through various pathways, but something about the way in which the whole system is set up. Is there something about that, the dynamics of the system that tell us something? And so system dynamics can often be used as a kind of first step to try and unpick a particular problem. So we're going to talk about both qualitative and quantitative system dynamics today, because both are used, and they both have uses, and you may do either or both, indeed, for many of the problems you look at. But we're going to start with qualitative, which basically just means there's no numbers in it. And the way in which we do qualitative system dynamics is we basically build a causal loop diagram. Some of you may be familiar with that. It's certainly not unique to system dynamics. So basically, within the qualitative system dynamics approaches, we create a map of the influences within a system and their directionality. And I'll come back to what that means in a minute. And by doing that, we then start to identify what are known as feedback loops within our map, which we call a causal loop diagram. And by drawing that map and identifying the feedback loops, we can draw some insights from what we've developed to try and identify, are there particular issues in aspects of the system? Is there something about the way in which this part of the system is structured that is therefore causing the problem? So here's some example influences that we might have in a causal loop diagram. So we might say we've got the number of people who are accessing GP services, and that will influence the waiting time to see a GP. Okay, and what this plus sign here means, we have going to have pluses and minuses. And basically that indicates, and this can be a little bit confusing, it's not an increase or a decrease. It represents the polarity of the influence. And by that, I mean, do the two things go in the same direction, or do they go in opposite directions? Okay, so a plus means they both go in the same direction, whereas a minus sign means they both go in opposite directions. So here we've got an example of a plus polarity where they're both going in the same direction. In other words, as the number of people accessing GP services increases, the waiting time to see a GP increases. So as that goes up, this goes up. They're both moving in the same direction. So we've got a positive polarity there. Similarly, though, we can have negative polarity. So here we've got that the number of people admitted to hospital influences the number of beds that are available in hospital. Okay, pretty obvious. But of course, this is an example of a negative polarity, because as the number of people admitted to hospital increases, the number of beds available decreases. Okay, so as this goes up, that goes down. So that's a negative polarity. So we indicate that with a minus sign because they're both going in different directions. Okay, you might think, well, why is that important? We'll see in a moment. Okay, so plus sign means both going in the same direction. It doesn't mean increase. So this also means as the number of people accessing GP services goes down, the waiting time to see a GP goes down. Okay, so it's not does it go up or down, it means same direction or opposite direction, and that can be a little bit confusing, can trip some people up. To be honest, it's a pretty stupid way of indicating it, because of course you'd think that's what it means, rather than polarity is a little bit that is the convention in system dynamics. Okay, so basically we build in a causal loop diagram lots of these interlinking influences. Okay, but occasionally what we see happen is we see loops emerge within our causal loop diagram, things that sort of go around and come back to the start. So here's an example, and we've got different types of loops that we can have. And the first type is known as a reinforcing loop, which you may have sort of come across in everyday life, something you perhaps call a vicious circle, or indeed a virtuous circle. It might be something that's very positive. Usually they're negative in these things, but sometimes they're positive. So a reinforcing loop, what does that mean? Okay, well, here's an example of a reinforcing loop. So here we've got the number of people who are accessing GP services, and that's going to influence the waiting time to see a GP. The waiting time to see a GP is going to influence the number of sick people in the community, and the number of sick people in the community is going to influence the number of people accessing GP services. So it goes round on itself. Okay. Now, if we look at the polarity of each of these influences, so number of people accessing GP services, well, as you've got more people accessing GPs, then the waiting time to see them is going to go up. So as that goes up, that goes up. Similarly, the waiting time to see a GP, as that increases, the number of sick people in the community increases. And as that increases, the number of people accessing GP services increases. So you can see, as we talk that through, it's a kind of a snowball effect. It's a reinforcing, it's a vicious circle. Okay, that's going up, which is causing the waiting time to go up, which is causing more sick people, which means even more people are accessing GP services, which is further increasing the waiting time, and it's snowballing. Okay, so the way in which we identify a reinforcing loop is that they have either an even number or zero minus signs. Okay, so in this case we've got zero minus signs, we've got zero negative polarity influences, so it's a reinforcing loop. But if we had two in here, that would also be a reinforcing loop. The overall net effect would be that it would cause if something in there is increasing, it will cause everything else to gradually increase. Okay, and another way to look at it, as well as counting the pluses and minuses, is to talk through it and see if you reach the same conclusion each time you loop. So I'll show you an example of that. So the number of people accessing GP services increases. Remember that sentence. As the number of people accessing GP services increases, that's what I said. Then the waiting time to see a GP increases. As that increases, the number of sick people in the community increases. As that increases, the number of people accessing GP services increases. I've just said the same thing that I did at the start. Okay, so I've reached the same conclusion as I've talked through that loop. Now, vicious or virtuous circles, they're very often reinforcing loops, but very often vicious circles, unfortunately, in problem systems, which is usually what you're modeling. They can be a particular problem when they spill out to other things. Okay, so you might have a reinforcing effect here, which is also then causing a problem elsewhere. And so we can imagine here that the number of sick people in the community may also be increasing the number of people attending A&E. So we can see here, this is a problem because we've got a reinforcing loop here, which means that if one of these things starts going up, everything starts going up, which means you've got spill out to this, which is, it's going to cause an increase over here. Okay, you've got a snowballing effect over here, and it's going to leak out over here. So that problem part of your system is causing an issue elsewhere. But we've also got things, as well as reinforcing loops, called balancing loops. And these are loops in which the influences balance themselves out. Okay, so let's look at an example. I have to say these tend to be rarer, but you do find them. So we've got the number of people admitted to hospital. That will influence the number of beds available in the hospital. And that in turn influences the capacity to admit patients, which in turn influences the number of people admitted to hospital. So here we're saying the number of people admitted to hospital, as that goes up, the number of beds available goes down. Okay, so that's a negative polarity. As that goes up, that comes down. Okay. As the number of beds available in the hospital goes down, the capacity to admit patients also goes down. And as that goes down, the number of people admitted to hospital goes down. Okay. Now, if you think about this, it's balancing itself out. It has to, because otherwise you'd have a ridiculous system. Essentially, it's demonstrating a system in which you have a constrained resource, in which you've got a limited number of beds. So you can't possibly, you may have 10,000 people that need to be in your hospital. If you've only got 1,000 beds, you can't take all of those people. So therefore it will balance itself out. You're not going to have a reinforcing loop where they're all coming in, but you don't have the beds full. So you've got a balancing effect going on. And balancing loops usually indicate something where a part of your system that you don't need to worry about, or that you want to encourage, because actually it's balancing itself out. It's not causing this constant reinforcing effect that usually is negative. So these are harder to spot very often. The balancing loops basically have an odd number of minus signs. So in this case, we can see we've got one minus sign and two positive signs. So we've got, this is definitely a balancing loop. The other way we can do it is, again, like we did for a reinforcing loop, we can talk through it and see if we reach a contradictory conclusion. So again, I would do that. So remember the sentence, as the number of people admitted to hospital goes up. Okay, so that's what I said. As the number of people admitted to hospital goes up, as that goes up, the number of beds available goes down. As the number of beds available goes down, the capacity to admit patients also goes down. It's a positive polarity, they go in the same direction. And as the capacity to admit patients goes down, the number of people admitted to hospital goes down. Okay, so I've said a different sentence. I've said the opposite now. When I've got back here, initially I said the number of people admitted to hospital goes up. And then when I came back round, I said the number of people admitted to hospital goes down. So I've reached a contradictory conclusion. It's probably easier just to count the minus signs, but it can help you to understand what's happening in these kind of loops. Okay, let's take it back to basics. Let's consider a very simple real world system. We're going to look at the system of the chicken and the egg. Now, stand by, this is going to get complicated. Chickens lay eggs. Okay, I think we're all happy with that. Eggs hatch into chickens. Okay, well, that's our system. So that's the chicken and egg system, and we can express that as a system dynamics system because we can indicate the polarity of these influences. Because more chickens means more eggs. More, as the number of chickens increases, the number of eggs being laid by chickens increases. Similarly, as the number of eggs increases, the number of chickens increases because eggs hatch into chickens and chickens lay eggs. So we've got a reinforcing loop. Okay, we've got something, a kind of snowballing effect, where as the number of chickens increases, it increases the number of eggs, and as the number of eggs increases, it increases the number of chickens. Okay. Before we go on, we will stop now for a group exercise. So what you're going to do initially is you're going to work in your groups. You're going to have about 40 minutes. I want you to build a causal loop diagram, the kind of diagram I just talked about, with different influences and linked to each other with the different polarities of influence, that describes the causal influences that influence people adhering to social distancing and other preventative measures during the early days of the COVID-19 pandemic. So how I want you to approach this is, and be as creative as you like with this, start in the center by writing a few different measures that may be put in place. So you might have things like number of people wearing masks in required settings, number of people staying 2 meters away from individuals not in their household, number of people washing their hands regularly for at least 20 seconds, that sort of stuff. Okay. Once you've written a few of those, start thinking about as many factors as you can that will directly influence each of those numbers. Okay. And which are directly influenced by the number of people adhering to these measures. So things that influence these things and things that these things themselves influence. Okay. And for each, I want you to note with a plus or a minus for each arrow that you draw. Put a plus or a minus to indicate whether the polarity is that they're both going in the same direction, plus, or they're going in opposite directions, i.e. as one increases, the other decreases, put a minus. And then start building it out. Okay, so think about, okay, well, the things I've written here that influence this, what are other things that influence that? Or does this thing influence other things? So start sort of gradually sort of building it out. And again, put in the arrows and put in the polarity of each influence. And as you're doing that, start looking for causal loops. Okay, whether they be reinforcing loops or balancing loops, start looking for them. And they can get a bit hard to spot as you're sort of building these up, but look to see if there are loops emerging within your map. Note any that you find, and based on that, can you draw any insight from the map that you've developed? So you can do this however you like. The basic idea is just to get used to using and drawing these causal loop diagrams. So it doesn't have to be these things you put in the middle. You can put whatever you like, but just build up a map of influences for every influence that you put in. Indicate if it's a positive polarity, i.e. they both go in the same direction, or a negative polarity, and keep an eye out for loops. I suggest I'll give you about 40 minutes or so. I'll tell you what, we'll resume, and make sure you take a sort of break as well before we come back. So let's come back about 10:40. Okay, right, I will open up the breakout rooms and I'll float around if anybody needs any help. Hi everyone, welcome back. So managed to get around to quite a few of the groups doing that exercise. Saw some really nice loops and diagrams that you'd come up with. So I'm going to ask a couple people, a couple groups, just to share what they've done. So whoever was sort of screen sharing, if you want to sort of talk us through. So we'll bring up the wheel of names, I think. And see who we're going to have first up. So I've already shuffled these. Let's see who we're going to have first up to present. Some really interesting stuff that came out of all of these, actually, I think. Okay, looks like it's going to be Amiga 500. First up, somebody want to take us through what you did on your diagram?
Yeah, no problem. I'll just start sharing. So we started dropping everything in as variables. We did have a look at some different options. We put in the kind of three main categories of actions at first, and kind of worked our way through then kind of what would be affecting that. We put lockdown status as kind of you're either in lockdown or not. So that was a binary option. So if we look at kind of the number of people staying 2 meters away from each other, we've put that major sporting events encourages lots of people to gather together. So therefore that's going to reduce the number of people that are going to stay 2 meters apart. Same with good weather. People like to join together in the pub. The school or workplace closures actually would increase the number of people staying 2 meters away from non-household. And holiday festivities around Christmas and other religious events encourage people to kind of get together. We've also got things like vaccinations and kind of how that influences kind of the number of infections that are detected. Free COVID test availability. If they're free, more people are likely to test, which obviously then affects the number of infections. As soon as we've taken away the free COVID testing, nobody really knows exactly how many infections are really taking place. So yeah, we just started kind of dropping things in and then linking it together and then trying to work out what kind of effect that would have on the different options. Yeah, that's kind of where we got to.
Great, no, thank you. So did you identify any loops at this stage?
I and it's a bit messy. I don't like the crossing lines, but we were trying to spread it all out. Things such as government policy will directly affect the availability of COVID tests. That affects the number of people that are tested, therefore the number of tests that are detected. That can also influence the number of people that will stay away from each other. Some people are quite happy to test before they meet in big groups. So
I wonder as well if there's a link back from number of infections detected to government policy as well, because whether that's one of the drivers. That could indeed be a closed loop, that policy drives free testing availability, which affects number of people testing, which affects the number of infections detected, which in turn is also directing government policy, and probably I suspect some sort of balancing loop, I would imagine, happening there. But yeah, really interesting, fantastic. Thank you very much. Okay, so let's pick another group and see who's next up. Spin the wheel again. Who's it going to be this time? Ooh, just edging into IBM PC, I think. So somebody from IBM PC wants to share your diagram, talk us through your insights.
Hi, that's going to be me.
Oh yeah, okay.
So I was a little bit more messy than the last one. I apologise. Okay. So we just focused in on the masks. So we've got the number of people wearing masks here. So we thought about, let's start maybe from the daily reported number of COVID cases. So we thought that would probably lead to an increase in TV and radio awareness campaigns, which feeds into public awareness, and an increase in public awareness likely increases the number of people wearing masks, and hopefully the number of people wearing masks leads to a reduction in the daily reported number of COVID cases. So that's a kind of a balancing loop there, I guess. There are a few other things that come off of it. So if we just come back to the number of people wearing masks, we thought that there was, as more people wore masks, that increased public awareness, which increased the number of people wearing masks, which is, sorry, Dan, I forget the terminology here, like an increasing loop, I guess.
A reinforcing loop, yep.
A reinforcing loop. If we come back from the daily number of reported COVID cases again, we can see that that links down to
Oh, I think we've lost you, Nick, unless it's me. No, can anyone hear me?
Just I can hear you, Dan.
Not me then. That's right. Something worried my internet connection had gone. Okay, cool. I think we may have lost Nick. It came up with a little icon.
Hello.
Oh, you back? Oh, fantastic.
Hey, yeah. Apologies about that. So again, we thought the number of daily reported COVID cases increased the number of rules and regulations, which might increase the availability of masks, which increases the number of people wearing masks, which again then may have a balancing aspect in decrease the number of reported cases. We also thought that there was a bit of a link in daily number of cases reported, TV and radio campaigns, public awareness. Public awareness maybe increased testing, and increased testing would have increased the daily reported number of COVID cases. We thought just a little loop down here where the daily number of reported cases would have led off to other complex systems of other preventative measures, which would have fed back to a decrease in the number of daily reported COVID cases. And then we just had a few other aspects up here that we didn't really work in, but definitely would have had an impact on the system, such as temperature or weather, social values. We thought that, for instance, as public awareness increased, misinformation also increased. So that would have had an impact on the system, but we didn't have time to really kind of map that out. And then also research, research being undertaken, for instance, on the efficacy of mask wearing would have impacted the system over time. So that's what we got to.
Brilliant. No, thank you. Some really good loops I think you picked up there, and interesting as well. You picked up the things about misinformation and you know, ongoing research and stuff. I think because that's quite an interesting loop that you identified there around you sort of public awareness and mask wearing. And a few of the groups I saw picked up on stuff like that, and that can go in both directions. That, you know, the more people you see wearing masks, the more likely it is you're sort of wearing masks yourself. But of course that can go in the other direction. We kind of saw both during the pandemic as well, that you know, at the start perhaps that was more of a sort of an increasing effect, but as perhaps other things were sort of feeding into that it almost sort of changed direction, and that increasingly fewer people wearing masks, and therefore that led to a reinforcing loop where people saw fewer people wearing masks, and so they tended to wear masks less often. So yeah, really interesting, fantastic. It's great, some great diagrams, and I saw some really nice stuff. So I'll ask you all later to share those on Slack if you can, so that everyone can see them, because I think that there's some really interesting stuff that came out of that. Okay, so we've had a go at qualitative system dynamics, or causal loop diagrams, as we call them. So let's now move on and talk a little bit about quantitative system dynamics. Okay, where there we go. Right, so far we've looked at causal loop diagrams. We've looked at essentially things that influence other things and the kind of directionality of those influences, to give us an idea about where there may be issues within the system. And quite a few of you picked up actually in the kind of systems you were looking at that actually there was quite a lot of balancing stuff going on, which is what you'd expect. It's kind of it's a controlled system that you know, when things are getting out of control, something steps in to kind of control that. You know, we didn't, and that happened. That's a thing in a pandemic. You don't if you did nothing, then things would just spiral out of control. But even then, you'd eventually reach a peak where, well, there's no more people that can be infected, for example. So there are all sorts of complex dynamics going on there, but a lot of the control measures put in place to sort of balance things out. But let's go back now and talk a little bit about quantitative system dynamics, where we're going to actually plug in some numbers to some of this stuff. So let's go back to our very complex chicken and egg system. Remember, we said that chickens lay eggs and eggs hatch into chickens. More chickens means more eggs means more chickens. So we've got, in this simple example, a reinforcing loop. So we can build for this little system a quantitative system dynamics model, because we can actually attach numbers to these rates that will describe the rate of flow between the elements in our system. In other words, the rate of flow between chickens and eggs, and between eggs and chickens. So in this system, that means how many eggs that chickens are laying per unit of time. That describes the rate of flow from chicken to egg, and how many eggs are hatching into chickens per unit of time, which describes the flow rate from eggs to chickens. But first, we need to understand a little bit more about some of the quirks and ways in which system dynamic models are actually built. So core elements of, and there are some other things that we won't sort of touch on today, but the core building blocks of a system dynamics model are these things here. So the first thing, and system dynamics models are very often something used to be known as stock flow models. You may have heard them referred to as that, because the fundamental building blocks of system dynamics models are stocks and flows. So we can think of stocks as things that hold the stuff, whatever it is, that's flowing around our system. And it's quite useful when you're thinking about a system dynamics model to imagine a kind of a plumbing system, and water flowing around your system. And it's quite a nice analogy for understanding some of the ways in which system dynamics work. So you can imagine stocks as being a bit like water tanks, that you've got water flowing around your system, and the stocks are holding various quantities of water. Okay, but obviously what your water represents will be different depending on what your system is. So those are stocks. It holds stocks of this stuff. Then we've got flows, and flows link the stocks together. So flows basically allow the stuff, whatever it is that's moving around your system, to move around. Okay, and the rate at which the stuff flows between stocks is controlled by a valve. So again, think back to think of a water system, a plumbing system. You're imagining water in various water tanks, and then water flowing through pipes into other tanks. Okay, and that water may flow at different rates. So the fundamental principles are: we've got stocks that hold the stuff, a quantity of stuff at any time, and flows which allow the stuff to flow from one tank, one stock to another, and the rate of that flow can be adjusted. Now, the things that, so they're the two primary building blocks really of a system dynamics model, but these things allow us to specify how this kind of works. So we have these things called variables, which are much like in coding, they are things that store some information. But specifically in a system dynamics model, we talk about a variable as something that represents something, stores some information that isn't otherwise captured in our system. It's not really a stock or a flow, it's something else, but it stores some information that will affect either the level of a stock or the rate of flow into or out of a stock. Okay. And then we have these things called links, and links are, so unlike flows, which is basically like a pipe which connects one stock to another, and the stuff that's flowing around your system will flow through the flows. A link basically says this influences this, a bit like what you've just done on your causal loop diagrams. It's stuff isn't flowing along a link, it's just saying this will influence this. So a link indicates that a stock's level, the level of a stock, or a flow rate is affected by either another stock's level or by a variable, and we use a link. So we might say, well, this flow rate, laying of eggs, is influenced by this variable, laying rate, and so we create a link. There's no flow between laying rate and laying of eggs, because laying rate isn't a stock, it doesn't hold stuff, it just holds some information. But we can link laying rate to this flow rate, laying of eggs, and say that variable influences the rate of flow between one stock and another. Okay, so let's go back to our chicken and egg example, and let's say that we know that chickens lay on average 5 eggs per week. Okay, and fertilized eggs take on average 21 days to hatch. Now we're going to assume this is a very simple system that we're building here, and we're assuming there's nothing else going on at the moment. We'll come back to that, and we're going to assume that all of the eggs are fertilized for simplicity here. Okay, so in our model we're going to start with 100 chickens and no eggs. That answers that whole question. Okay, so we've got 100 chickens and no eggs, and let's say that we want to track our chicken and egg populations over time. What do you think will happen in this system?
Well, they'll just increase exponentially over time at the moment.
Yeah, so we're probably going to see some sort of exponential increase because there is no control on this. Basically, we're saying we've got 100 chickens, they're laying on average 5 eggs a week. They're going to hatch into more chickens, which are going to lay more eggs. We're assuming all the eggs are fertilized, which will hatch into more chickens. And we're going to get this kind of uncontrolled growth. But we can build a model, and I'll show you them in a moment, to actually look at this. Before we do that, though, oh, sorry, got a hand up.
But only half the chickens who are hatched will be females, which will lay other eggs. So
yeah. Yeah, that's you're right. So we're essentially this very simplistic system. We're assuming that all of the chickens are able to lay eggs. So we're assuming they're all of the eggs are fertilized and hatch into female chickens. So yeah, you're absolutely right. Yeah, this is a very simplistic system. We'll see a little later how we'll build in a bit more complexity into it and how that will change things. So system dynamics models, they're a little bit different to the stuff you've kind of seen before in things like discrete event simulation and agent-based simulation. particularly if you're comparing it to discrete event simulation. You'll see some quite fundamental differences in how this works. So one of the most difficult things to get your head around initially is that the entities that are flowing through the model, so whatever your stuff is not represented as individual entities that are flowing through. So in a discrete event simulation, you have people coming in and they are queuing, and you might have 10 people in a queue, 12 people in a queue, but they are each individuals, and they will go into that activity and they will have something done to them, and then they will move to the next activity. Similarly, in an agent-based simulation, the individuals are the heart of the system. It's all about them and what they do and how they interact and behave. But in a system dynamics model, they are not individual entities. They are a continuous mass of stuff. Okay, again, think of water. So you don't have any concept of an individual entity within a system dynamics model. You've got a flow of stuff that's sloshing around your system. The other key thing to note with this dynamics model is that they are, unlike a discrete event simulation where we say we typically build randomness into our model. They are stochastic models because we know that not every patient will spend X amount of time with the nurse or whatever it may be. And we build in randomness. We talked about how we use distributions to say we'll account for variability within our real world systems. And so when we run a discrete event simulation, we get a slightly different result every time, and that's why we run them lots of times, and then we kind of take average results over those runs to get a sense about what's actually happening in the system. Because you might have runs of good luck, runs of bad luck, etc. Because there is randomness in it. A system dynamic model, in its purest form, is not stochastic. It is deterministic. That means every time you run that system dynamics model, you'll get exactly the same results because there's no randomness involved. Now you can in package, I believe you can in InsightMaker as well, but you can because I've done it before. You can incorporate distributions into it, but strictly speaking, that's not pure system dynamics. A pure system dynamics model is deterministic, and in fact, if you're going down the route of bringing in distributions, you need to think carefully about whether system dynamics is the right tool for you, because what you might actually be trying to do is build a queuing model and you're trying to fudge it in system dynamics. That happens quite often. So think carefully about what you're trying to do, because really system dynamics models, and this goes into the third point, you're not interested in the kind of questions that are things like how many doctors do we need to meet this demand, Y% of the time. That's a discrete event simulation kind of model. With a system dynamics model, you're basically zooming out, looking at it at a very high level, and you're kind of interested in the general patterns, the general dynamics within your system. Much in the same way that you were starting to look at a bit of insight into your causal loop diagram, say, oh, okay, that's quite interesting that we see over here that there's a kind of reinforcing effect going on around people wearing masks and seeing other people wearing masks and things like that. It's that kind of insight that you get from a system dynamics model. Even a quantitative system dynamics model is really giving you that kind of insight more than you don't tend to use them for things like, okay, well, if we take a doctor out of the system, how's our system going to behave? It's not really for that kind of thing. You can do it, but you're essentially fudging a discrete event simulation into a system dynamics model. So a proper system dynamics model is all about getting a feel for, is there something, remember, structure determines behavior in a system dynamics model. Is there something inherent in the structure that gives us insight into what might be going wrong in the system? And in fact, a good use for system dynamics models sometimes is to try and unpick a complex system and say, actually, I think we seem to have there's something about the way in which the system is set up over here. Maybe we need to look at that. Maybe that's where we need to focus in. And it may be then that you say, well, actually, okay, yeah, there is a problem over here, and actually that we need to sort that problem. And that problem, it turns out, is a queuing problem. And so I'll build a discrete event simulation to try and solve that queuing problem, because I know if I do that, the system dynamics model tells me that if I can solve that problem, it'll impact on things over here. Okay, because that is spilling out, that problem over there is spilling out into this. So these are the kind of three things I want to flag up, really. The fact that you are dealing with continuous mass of resource, continuous mass of entity, not individual entities themselves, that your models are stochastic, they are not deterministic. So you're getting the same results every time, and that you're interested in those kind of general patterns, the general dynamics in the system. So let's have a look at some of this in terms of our very simplified chicken and egg model. So we said that eggs take on average 21 days to hatch. And let's imagine that we've set our time unit in our model. We can set it much like discrete event simulation or agent-based simulation. Our time unit can represent whatever we like. So we're going to say, well, our time unit represents weeks, because we know that chickens are laying on average 5 eggs a week. So each time unit in our model represents a week in which, chickens have laid some eggs. And we know that chickens are laying on average 5 eggs a week. So how do you think we would describe the number of eggs that are hatching per week? Any thoughts? No? Okay, it's a bit odd, so I'll talk you through it. So on average, an egg takes 21 days to hatch, so 3 weeks. And we know that chickens are laying on average 5 eggs a week. And as I say, we're assuming simplification, we're just modeling female chickens and fertilized eggs. All the eggs are fertilized and they all turn into female chickens. The way in which we would describe the number of eggs hatching per week, in other words, the flow rate from eggs into chickens, is the number of eggs divided by 3. So let's think about why we get that. Let's think about it. If we had 1 egg, okay, it would take 3 weeks or 21 days to hatch. But in system dynamics terms, because we're not dealing with individual eggs, we are dealing with a continuous mass of resource that is sloshing around our system. So in system dynamics world, an egg taking 3 weeks to hatch means that 1/3 of an egg would hatch per week. So that 1 egg, 1/3 of it each week would hatch. Now, obviously that's nonsensical in the real world. You can't have 1/3 of an egg hatching. But in system dynamics world, that's how it works. Okay, 1/3 of that egg has flowed away to become a chicken. If we had 2 eggs, then each week, 1/3 of each egg would hatch. It would flow into becoming a chicken. Which means after week 1, we'd have 2 1/3 of eggs hatched. Which, if we put it in slightly simpler terms, means we've got 2/3 of an entire egg hatched. We've got our 2 eggs, 1/3 of that one's hatched and 1/3 of that one's hatched, which means we've got 2/3 of an egg hatched. And that makes sense if we think about it, because after 3 weeks, if we had 2 eggs, we'd expect 2 chickens. And of course, 3 times 2/3 is 6/3, which is 2. So 2/3 of an egg each week would hatch if we had 2 eggs. So basically what we're saying is that the number of eggs hatching per week is whatever the number of eggs is multiplied by 1/3. i.e. 1/3 of each egg that we have is hatching per week. And we simplify that down to number of eggs divided by 3. Okay, it's a bit weird to get your head around, because of course you're not, in the real world, you can't have 1/3 of an egg hatching into 1/3 of a chicken. But that's what happens in system dynamics terms. Okay, so I wanted to flag that up because it's a little bit different to sort of get your head around, really. And it underlines this point that system dynamics is a very different kind of modeling method to the ones we've shown you so far. So I'm going to show you now the piece of software you can use. Sort of a few of you already sort of having a bit of a play around with it. It's a really nice piece of software, actually, that allows you to build system dynamics models really easily. And it's called InsightMaker, and you don't need to install anything. You just use it online, and you can save your insights and share them freely. And it's very much got a nice ethos of sharing models. It also, as well as doing system dynamics, it does do agent-based simulations. I've never looked at that in depth, My advice would be to steer away from it. I have used things like AnyLogic in the past when we used to use proprietary software many years ago, which was also so AnyLogic was an example of a system that was primarily for agent-based simulation, but could do system dynamics. Similarly, Simulate, the discrete event software that we used to use, could also do bits of, I think actually both, though, eventually. These things never, particularly for agent-based simulation, when we talked about the agent-based simulation before Christmas, agent-based simulation, you can technically do anything you want. The only things you have to worry about are you need some agents that interact and live in an environment. Anything else is up to you. So we saw it when we looked at Mesa, that essentially we use Mesa to say, okay, well, it's defined what an agent is. Here are all the things that I want my agent to be able to do. Here's the environment in which they live. But you can do anything you like. An agent-based simulation, because it's so open, I tend to avoid using framework software. Even AnyLogic, as I used to use years ago, was so restrictive because, of course, you can do anything, but you're then having to fight with the confines of a piece of framework software. So it's much nicer to use something like Mesa, where you say, well, okay, agent-based simulation could be anything. The only things that I need to know are that there's something called an agent, and there's something called a model that they will live in, and you know, I might want a grid to represent their environment and stuff like that, but basically it's up to me. And so with Mesa, it just says, well, we've got these things written for you. You can specify what an agent is. We know what that is now. Just tell us about your agent, and it's much more sort of open for that. And my general advice with agent-based simulation is to do that. So I haven't used InsightMaker properly for agent-based simulation, but I would be surprised if you were able to have the flexibility of something like Mesa, for example. And I think that's really important for agent-based simulation. But I can tell you that it is really good for system dynamics. And it is drag and drop. It's very easy to use. So let's have a little look at it. So if you, hopefully you've signed up for a free account on InsightMaker. When you do that, you'll be greeted with a screen like this, except it won't have some insights. These are things that I've generated before. And you should have a button, though, that says create new insight. So if I'll click on this just to show you, and you have a bit of a chance to play around with this morning. And it will show you a little demo model that you can have a look through in your own time. It'll show you some different things that you can do. I'm just going to click to clear that, and I'll show you some simple concepts here. So the building blocks that I talked about, stocks, flows, variables, and links, they're all up here. Okay, now the primitive button up here, if I click on that, we can see that I can add stocks, add variables, and I can also add converters. Don't worry about those, you can read about those in your own time. This stuff's for agent-based simulation, so you can ignore that. And there's some extra stuff that you can do down here around adding text boxes and pictures and interactive buttons, and there's some really nice features that you can use in InsightMaker. But at its core, we want some stocks, flows, and variables. Okay, so let's imagine I just want a very simple system where I've got a couple of stocks, one flows into the other, and it's driven by a flow rate. So if I click add stock, here I've got a stock. I can drag that around wherever I like. And if I double click on it, I can rename it. So I'm just going to call mine stock A. It's not very imaginative, but there we go. And then I'm going to have a second stock. I'm going to click primitive, add stock, and I'm going to put a second stock called stock B. There we go. And then I'm going to have a flow so that things from stock A flow into stock B. And to do that, all I do, there are two types. Remember, there's two types of kind of arrow in system dynamics. There's the flow, which means stuff actually moves from here to here. Or there's a link, which is saying stuff doesn't move between here and here, but this thing influences that thing. So here we want a flow. And that's the default option, but you need to make sure that the right one is selected every time you go to draw an arrow. And then if I hover over the stock that it's coming from, you'll see a little arrow appear there. If I left click and drag over to the stock I want it to go to and let go, it's created a flow. So now I've got a system where stock A is flowing into stock B. And I'm just going to rename my flow by double clicking. I'm going to call mine A to B. Again, not very imaginative, but there we are. But I'm also going to control this flow rate using a variable. So I'm going to add in a variable here. And I'm just going to put control rate for flow. And I need to say that this thing, whatever information is stored in here, is going to influence this flow rate. Okay, so now I need a link. So I'm going to click links up here. And then when I hover over and get my little arrow here, left click, I'm going to join this to this flow rate. And that now says that I can define my flow rate here, A to B, based on this thing. If I don't put that link in, it won't give me the option to reference the information that's stored in here. Okay. So I've got a very simple system dynamic system here. If I click on each of these elements, we can actually configure it a little bit. So if I click on stock A, you'll see this information, I'm just going to move that up a little bit. This information appears on the right panel here. The first thing here, it says initial value. So this is how much quantity of stuff do you want at the start in this stock. It'll always default to 0 for everything, which means if you ran it, nothing would happen because there's nothing in your system. So I'm going to have it such that there's 100 units of stuff in my stock A and nothing in stock B. Okay, so I'm going to change that initial value to 100 in stock A. Oops. I never understand this. By default, it allows negatives. It allows you to have negative values. So in other words, once all of the stock had flowed out of stock A, it would keep flowing out, even though there was no stock left. I find that really odd. There may be some circumstances where you want to do that. Typically, you don't want negative. You want to know when something is empty. So make sure to turn that off unless actually that's what you do want. Otherwise, you get really odd stuff. I just find it really odd that that's the default. The conveyors we won't go into here, but they are a little feature that allows you to basically delay something flowing out. It's almost as though it comes in and then it goes on a conveyor belt. Think a little bit like putting shopping on a conveyor at a supermarket checkout. That it flows along for a period of time before coming out the other end. If you don't have a conveyor, then each time unit stuff will come out, regardless of when it came in. Okay. You can also do these things, enable value slider. I'll do that in a moment up here. But basically, it allows you to, much as we saw with Mesa for the agent-based simulation, it allows the user to then play around and change the number. Okay, so if I enabled that here, and I click off, that's not come up. Why is that not come up? Okay, that's a bit odd. Might have done something wrong. We'll come back to that. But it should come up with a little slider that enables you to change that slider value. Validation, don't worry about that. That's when you're doing some validation on your model, and you can read about that. So we've got 100 units of stuff at the start in stock A. We're not going to allow negatives. In stock B, I'm going to leave that empty at the start, and I'm going to turn off negatives. And then what I'm going to say is I need to define my flow rate. So at the moment, the flow rate also defaults to 0. That means that nothing will flow for each time unit. How many units of stuff flow from here to here? That's basically what that flow rate is. So by default, it'll be 0. So nothing will happen. But I'm going to set up a little equation up here. Okay. So if I click on this little box here, the expand box next to flow rate, I can actually create an equation. So what I'm going to do, I'm just going to create a very simple one that says the flow rate is double whatever is in that variable. Okay, so I'm going to create an equation that says 2 times, remember we use the asterisk, and because it automatically brings up here under references things that I can reference in this flow rate. So by default, the rate of flow between 2 stocks, you'll always be able to refer to the stock, the level in the thing it's coming from and the thing it's coming to. So you could create a flow rate that partly depends on how much is in the thing I've just come from and how much is in the thing I'm going to, or both. By default, it'll always have that. But because I've added this link into this variable, it's also brought up this option that I can refer to the control rate for flow, this variable that I put in. So I'm going to say that. I'm going to click on that. And now that says the flow rate from A to B per time unit you're going to flow out 2 times whatever the number is in control rate for flow. Okay, so if I click apply, that's now my equation. So now I need to go up and in my variable here, control rate for flow, again, defaults to 0. So I'm just going to put in a very simple number of 5 here. And I'm going to enable a value slider there. Not sure that's not, I think maybe it's because I'm, let's save it. Should come up on the right. There we go. That's why it's not appeared. So once you've saved it, it'll appear. So you can see now I've got a little slider here. Okay, and that means the user can then play around with that. So by default, this value is 5. And what should happen is that we've got 100 units of stuff in stock A, and every time unit, twice whatever value is in this variable will flow out of stock A and into stock B. And because we've turned off negatives, once this empties, there'll be nothing else flowing out. Okay, I've created a system dynamics model. So let's run it. If I click up here, so I'm having to move around my face. So there's a big button called simulate up at the top right. If I click on that, there we go. That's my first model. Now let's have a look. It'll create some default displays. You can play around with this, and we'll see some examples of that in a moment. That will show you some information. You can bring up tables. We'll see that in a moment as well. But by default, it'll basically put everything onto a graph. You may not be interested in everything. The control rate for flow obviously is not changing. It's static. It's just the value 5. So it stays as the value 5. So you're probably not interested in that. And you can configure it. So you can say, well, I'm not interested in mapping that. But what we see here, if you ignore the yellow line, is a blue line, which represents stock A, and a green line, which represents stock B. So stock A, remember, starts with 100 units of stuff. Stock B starts with nothing. So at time unit 0, if I hover over there, we can see there's 100 units of stuff in stock A and nothing in stock B. After 1 time unit, we've got 90 in stock A and 10 in stock B, because remember the rate of flow we've set as 2 times whatever the control rate is, and the control rate in this case is 5. So 10 units of stuff will flow out. And we see there's just a linear decrease in stock A and a linear increase in stock B until stock A runs out of stuff, and there's then no more flow after that. Okay, really simple model, and built that essentially in seconds. Okay, now obviously in reality you'd create a bit more complexity, which you can have a bit of practice doing, but that's the basic principle. You slap down some stocks, you put some flows between those things, and you define the flow rate based in part on perhaps variable values, on stock levels, however you like. But it's really easy to build these little simulation models. Okay, so let's now have a look at what I made earlier in true Blue Peter fashion. So we're going to have a look at this one. This is a link to that model, where we're going to look at the chicken and egg model. This is the chicken and egg model as a system dynamics model. Okay, and this might not be quite what you expected. You might have expected to see 2 flows, a flow from eggs into chickens and a flow from chickens into eggs. Why don't you see that?
Because chickens don't become eggs.
Absolutely, exactly so. So an egg becomes a chicken, but where a chicken is laying an egg, but it doesn't turn into an egg. Okay, if it did, then you would see indeed 2 flows there. So we have to represent this slightly differently. But let's have a little look at this system. So if we have a look at our 2 stocks here, we've got chickens and eggs. So at the start, remember we said we're going to have 100 chickens in our model at the start. So I've got a stock here called chickens that's got 100 as the initial value, and we're going to have no eggs. So I've got stock called eggs that's got an initial value of 0, and I'm not allowing negatives for either of these things. So let's start with the eggs hatching into chickens, because that's a bit easier. Because an egg does indeed become a chicken for the purposes of this. So we've got a flow rate that I've called eggs hatching, and when you're naming these things, it's good to make sure you're very careful about how you name them, that it describes what it is. So you tend to want kind of nouns for your stocks, because they're holding a quantity of stuff. But for your flow rate, you tend to want a kind of sentence, an active sentence that describes what's happening using verbs. So here we're saying, well, this flow rate represents eggs hatching. That's what that flow rate is. Okay. So here my flow rate, remember we said the eggs hatching, the rate of flow is eggs over 3, because a third of an egg is being hatched every week. So it's number of eggs times a third, which is eggs over 3. You could write it as a number of eggs times a third. It's the same thing. But here I've just set that up as eggs over 3. And if you look at the equation, you can see because we've got a flow between eggs and chickens, I can refer to either of those things. So here I'm saying whatever the stock level is in eggs divided by 3, that's how many eggs will become chickens per time unit. So that's relatively straightforward. Now for eggs into chicken, for chickens into eggs, that's a little bit different, because chickens aren't becoming eggs. The number of chickens is influencing the rate of laying. Now, something I didn't show you, let me just go back to this. Sometimes in your system dynamics model, you're going to want to create a flow from nothingness into a stock, or a stock that flows into nothingness. If you want to create a flow from a stock out into nothingness, that's easy. You just click flow, draw it as normal, and then just don't connect it to anything, and it'll just flow. It's like an exit from your system. It just flows into nothing. Okay, so that's easy. But if you want to create a flow from nothingness into something, into a stock, then you're it's a bit like a sort of a generator in discrete event simulation. You need to do this slightly differently. So the way you do it in InsightMaker is you create, let's say we want to flow from nothingness into stock A. I'd first create a stock here. I then create a flow into that stock, and then I just simply delete the stock. Okay, so now I've got a flow from nothingness into stock A. It's a way for things to come into our system. Without that, this is a closed system. No more than 100 units can come into our system, because we've started with 100 units in stock A and nothing else is coming in. But by doing that, we can by creating a flow into the system, we can control things, new things entering, and that's effectively what's happening here. We've got new eggs that aren't there at the start that are being created, and the rate at which those eggs are being created is in part determined by the number of chickens, as in part determined by what I've called the laying rate. So if we have a look at the laying rate, so we said that chickens lay on average 5 eggs a week. So I've said basically the laying rate here is 5. It represents the number of eggs. In fact, it's probably not very well named. I should have called that number of eggs hatched by number of eggs laid by a chicken per week. That's what it is. So then the laying of eggs, I link using links. I link both the stock level of chickens and this variable laying rate into this flow rate, because the rate at which new eggs come into being is determined by both the number of chickens and the number of eggs that each chicken lays. And it's simply the number of chickens times the laying rate. So if they're laying 5 eggs a week and you've got 2 chickens, then it'll be 10. Okay, so I've just set that up as a really simple equation here. Just said whatever the stock level is in chickens, multiply that by this laying rate. So if I run this very simple model, we can see what's going to happen. So if I click simulate, now let's have a look at the graph first, which I think was one of these. Yep, there we go. So this is mapping here chickens and eggs. Chickens is in our blue line here. Eggs is our green line here. And we can see, as you rightly predicted, there's basically an exponential increase. And it appears to be just happening here. It's because of the scale. So it's auto scaled the graph. But of course, this is an exponential increase with incredibly high numbers. And in fact, if we can look at this in our table display here, so if you want to, I didn't show you this, but if you want to add a display, you just click add display, and you can choose between a time series, which is a simple graph, scatter plots, tables, agent map you'd only use for agent-based simulation, and you can select what you want to plot on each thing and how you want it plotted. So if we go back to the table here that I've set up, we can see our table. In fact, if I go back to the slide, I might make it a bit easier to talk through. So here, at time unit 0, we've got 100 chickens and no eggs. Okay, that's what we said we'd have to have at the start. After the first week, at time unit 1, we've still got 100 chickens, but we've now got 500 eggs, because each of those chickens, 100 chickens, has laid 5 eggs. So we've now got 500 eggs. After 2 weeks, we've now got 266 2/3 chickens and 833 1/3 eggs. Let's think about why that is. So for the chickens, we've got 266.66. That's the 100 chickens we had before, plus 500 over 3 new chickens. Because remember, a third of the eggs, a third of each egg has hatched. The number of eggs divided by 3 has hatched into chicken. So 500 of these eggs divided by 3 gives us another 166.67 chickens. Similarly, for eggs, we've got the 500 that we had before, plus 500 new eggs, because another week has gone by. So those 100 chickens have laid another 500 eggs. So we've now got 1,000 eggs, but some of those eggs have now hatched into chickens, even though they wouldn't have in the real world. But in system dynamics world, 500 over 3 of those eggs originally have now hatched and become chickens. Okay, so it's a bit weird to get your head around, but it goes back to this point of a bit of an egg is flowing into a chicken, a bit of a chicken, I should say. Does that make sense in weird system dynamic world? So we can see that that exponential increase, and we can see what's happening. And in fact, if I go back to the table here, we can see that after 52 weeks, after a year, we've got ridiculous. We've got a population explosion of chickens and eggs. That's in part because we've vastly simplified this chicken and egg population. For a start, we've assumed that all the eggs are fertilized, that all of the eggs are female, so all the chickens are female. Chickens never die. So we've got all of these things that we've simplified the system with. But if that were true, we clearly got a chicken egg population explosion. Okay, time to go on to an exercise. Now, what we're going to do here is you're actually going to get a choice of what you want to do. So I want you to decide in your groups, first of all, which of these exercises you're going to undertake. One of the exercises will basically sort of tell you, build something that does this, whereas the other exercise gets you to be a bit more creative. So it's entirely up to you what you do, but have a chat about it as a team, first of all. So the first option is that you would expand this chicken and egg model that I've shown you, which you can link to it. So if you click on the link, you can take a copy of that chicken and egg model, and you do that by cloning the Insight. You click on Clone Insight, and then it creates a copy in your sort of online storage space of that model, and then you can play around with it however you like. And then you would make these changes to that copy of the model. So we said, well, in reality, not all eggs are fertilized. So I want you to make the proportion of eggs that are fertilized a user-definable variable with a slider, and that defaults to 1. But you should only model fertilized eggs in your model. So we recognize that not all eggs are fertilized, but we're only going to model fertilized eggs. I want you to capture the fact that chickens can either die through natural causes or predation by foxes. To do that, I can tell you that chickens have an average lifespan of around 7 years, and foxes give birth to around 5 kits per year. So I want you to start with 100 foxes in the model and no kits. So yes, you're going to have to model foxes and kits too. Kits move into adulthood, and for the purposes of this, we mean when they start finding their own food at around 12 weeks of age. And foxes have an average lifespan of 4 years. And we're going to make an initial assumption that each fox kills 1 chicken every 5 weeks. But we want you to make that a user definable variable so the user can change the fox chicken murder rate. It's a very odd model that you'll be building here. Once you've built your chicken murder simulator, you can use this expanded model to answer the following 2 questions. That, first of all, assuming all else is as above, what is the minimum proportion of eggs that need to be fertilized to ensure our chicken population doesn't die out within a year? So the first one you're looking at, you're building it on behalf of the chickens. And then the second question, the foxes have approached you and said, well, look, if 80% of eggs were fertilized, how much more regularly would we foxes need to kill chickens to make the species extinct within a year, which actually is a bit counterproductive. I don't know why they'd want to make it extinct. They'd have no food then. But anyway, they've asked you to do it, and they are the customer at the end of the day. So that's your first option. So you could do this. Yes, sorry, there's a hand up.
Hi, sorry if I've missed this. Did you show us how to set the time value? Is that something we need to be able to do for doing this? Because you're talking about weeks and years and things.
So the time, so by your whatever your unit of time, it just works in units of time. So you can use that to represent whatever you like, but it just needs to be consistent. So for this, you'd want to keep it as weeks. So a unit of time essentially represents a week. So
Okay.
anything else that you've got, you need to express in that unit of time.
Right.
Much like you do with a discrete event. Yeah. Okay, so that's option 1. Option 2 is this. That you forget about chickens and eggs, and you design and build your own system dynamics model of anything you like from scratch. If you do this, I want you to decide what your model is going to capture. You could even think about capturing an element of using the maps that you've designed earlier, but it doesn't have to be. It can be anything you like. You might have some real data to plug in. I doubt it, and you're time constrained, so you just plug in some estimates of numbers for now. For those groups that did this, we'll ask you to share links to your models. To do that, you'll need to make the Insight public if you want to share. So by default, any models you build are private, and nobody else can see them. I will show you very quickly how to make an Insight, which is what you call all the models in InsightMaker, public. So if we go into the Insight and click edit, no, sorry, not edit, edit info, this button here. And you can see, well, this one is public because I made this public so you could all access it. But by default, yours will say private. You just click that, and suddenly that's now opened up to the world. So anybody with that link go and have a look at it. And in fact, you could put little tags in if you wanted to, and that allows people to search for models. And in fact, on the main InsightMaker page, you can search for models. And you can, if you click Explore Insights, you see these are various terms that come up. So I'm going to type in COVID because there's going to be loads. And there we go. Oh, there's one by Chris Bealey there. Look, how weird. So we can look at various models that people have been building, and you can put tags to help people find them. Be warned, there's a lot of crap on there as well. A lot of people obviously use it and they play around with stuff. So don't take this as a there might be some bad models on there, but there's usually some interesting stuff that you can find too. Okay, so what we're going to do, we've slightly run over, but I'm going to give you as much time as possible. So if we come back about 20-25 past, and I'll ask a group or two just to present what they've done and have fun. So I'll open up the breakout rooms now. Decide first of all if you're going to do the chicken murder simulator or if you're just going to build your own model, and have a go. Start building up a model. Okay, let's open up the rooms. Hi everyone. Okay, welcome back. So hopefully you had a good stab at that. I didn't manage to get around to all of the groups because I spent about 15 minutes searching around my house, wondering why I could hear some sort of silent alarm that was going off. I was convinced it was the carbon monoxide alarm that was going off, and it turns out my wife was on a Zoom call and there was an alarm going off in their ward. So I spent 15 minutes wandering around. I did manage to get around to a few of the groups. Now, I all of the groups that I saw looked at the chicken murder simulator. Did anybody do their own, or did you all do the chicken thing? No, all chicken. Okay, cool. In which case, what I'll do, I would just talk you through. I've made the solution now public, so you will be able to. In fact, I will put the link to it in the chat, so you can have a look at this yourself before I share. Where are we? Chat. Okay, so this is the solution, or a solution, to the chicken and egg problem. I'll just very quickly talk you through it too. Yeah, that's the one, isn't it? So basically what we've got here is an expanded version of the chicken and egg problem, with fox predation in there too. Quite a few people understandably coming unstuck on some of the numbers, etc., that are needed for both birth and death of foxes and chickens. So I'll let you have a look at this properly in your own time, but I think most of you were pretty much there if you didn't quite get there. So kits being born, if a fox gives birth to 5 kits per year, then in system dynamics terms that means each fox each week would give birth to 5 52ths of a kit. So it would be 5 over 52 multiplied by the number of foxes that would give you the number of kits being born per week. The fox mortality, so we said they live for 4 years on average, so that would be 208 weeks, which means if you had a single fox, then 1/208th of that fox would die per week. And that's how it would work in system dynamics terms. So it would essentially be 1 over 208 times by the number of foxes, which we'd simplify to foxes over 208. And the same thing would be the case for chickens. Lifespan of 7 years would be 364. So it would be 1/364th of a chicken would die per week per chicken. So we'd have chickens over 364. And then basically the thing that would link them here would be, so we've got a chicken. I've got chicken mortality P, as in chicken mortality from predation, and I've just said that that's the fox predation rate times by the number of foxes, because of course the number of chickens being killed by foxes is dependent on both the number of foxes and how many chickens each fox on average kills. So that my chicken predation rate is 1 by default, and if I simulate that, we can see let's have a look at the chicken versus foxes graph. Initially, by default, the chickens are exploding in terms of their population, and the foxes are taking over. Did anybody get to the point at which they got the numbers for this, for the answers to the questions? No, possibly not. So we had. Let me bring up the solution so I can remind myself. So you should have found that you need at least around 8% of eggs to be fertilized to ensure the chicken population didn't die out. And if you're looking at it from the perspective of the foxes trying to kill the chickens, that foxes would need to kill chickens around 5 times more regularly, i.e. 1 chicken per fox per week, to make chickens extinct within a year. So have a look at that solution in your own time as well, so you can have a look at how that's been built. Sorry, yes, you do need. I've just seen in the chat you do need to rate for kits to adulthood. Sorry, I forgot to show you that bit. Bring that back up. So here I've got kits and foxes. So I've separated those things out. So kits flow into foxes; they become foxes. So kits reaching adulthood would be kits divided by the number of kits divided by 12, because we said that kits move into adulthood at around 12 weeks of age. So in other words, in system dynamics world, that means a 12th of a kit becomes a fox each week. So it would be 1 over 12 times by the number of kits, which is kits over 12. it's weird, isn't it? It's a very weird way of trying to think, but hopefully it's given you a bit of insight into, pun intended, into how system dynamics models can help you kind of get a feel for how a system is working. So in this case, we've got a bizarre kind of chicken population explosion happening, and how you might intervene to sort of control that in some way. But I'd encourage you to have a look at playing around with InsightMaker. Hopefully you've explored a little bit of it. There's some other things that it can do as well. It's got some really nice documentation and tutorials that you can follow to have a bit of a play around with this stuff, because it's really easy to use, really easy to develop this stuff. Yeah, have a go at building your own, and come up with your own system dynamics models that don't involve chickens and foxes, and see what you can come up with. But that's been a bit of a whistle-stop tour this morning of system dynamics and what it can do. And it might be that either the causal loop diagrams or some of the quantitative stuff that we've just looked at might be useful for some of your ideas. So we've overrun very slightly, so let's stop there now. We will be resuming at 1:30. We've got our guest lecture this afternoon on patient and public involvement. This is we met with them yesterday. This is a fantastic lecture that we've got lined up this afternoon. Really good, really interactive, and fantastic that we've got a patient from one of our patient representative groups coming along to talk to you as well. Such an important area, and something that we'll be expecting you all in your project pitches to be considering. So really important, and a really good practice that you'll get this afternoon in terms of thinking about how you might incorporate public and patient involvement in your own research ideas for your projects. So we will break there. As always, I will leave the call open. So if you want to stay on the call, that's absolutely fine. Just make sure you're muted and your camera is off. And we'll kick off again at 1:30. So
can I just check if there's anything we need to download this afternoon?
No. So there will be some slide, little PDF that Georgie will share during the session, but she'll give you a link to that.
Okay, thanks.
There's nothing you need to download in advance. There's no Python or anything this afternoon, so it's a nice light afternoon. Okay, great.
Thank you.
See you at 1:30. Hi everyone, welcome back from lunch. Hope you managed to get a nice lunch break and not have to think about chickens and foxes and eggs for a little while. So this afternoon, you're probably sick of my voice now, so we're going to hand over to our fantastic guest lecturers who are going to come along today and talk to you about patient and public involvement as such an important area for research and specifically for consideration for your HSMA projects as well. So we're delighted today. I've got Georgia, Lauren and Leon who are going to be delivering this afternoon's fantastic session. As I say, Elliot and I met with Georgia yesterday and heard all the details about it, and it sounds fantastic. So without further ado, I'm going to hand over to Georgia. Georgia, please shout if you need anything from me.
Thank you for that lovely little introduction. Let's see if I can share my slide without it rebelling against me. Oh, it's the moment of truth. Bear with me. I want to show it. There. Can everyone see my slides okay? You see what I can see?
Yeah, brilliant. Thanks, Georgia.
Suspiciously smooth. I said, hi everyone. It's really nice to be here today first off, especially since it's such a good little turnaround as well. So again, thank you for having us. So as Dan mentioned, in this section, we want to talk about this idea of patient and public involvement and engagement. I want to warn you in advance that I'll probably slip into this acronym of calling it PPIE. So what we really want to achieve in this section is that we want to understand what we mean by this term patient and public involvement, and also just as importantly, what is not considered PPI, because we see a lot of misconceptions around them. So we really want to kind of almost myth bust what it means. We also want to talk about why we do patient and public involvement and how we actually do this in practice. So it's been all the knowledge we put to the test and just going through a few little case study examples. So before we go on, I just want to briefly introduce myself. So as I said, my name is Georgia. I'm part of the patient and public involvement team at the University of Exeter, where I work as a research assistant. And I'm very glad to be here today with two of my colleagues who are also co-presenting. So if I pass on to Lauren, who can also introduce herself.
Hi, my name is Lauren. I'm also part of the PENARC PPI team at the University of Exeter. I'm one of Georgie's colleagues in the office, and I'll just hand over to Leon. Oh, Leon, you're on mute.
Thank you. Hi, everyone. I'm Leon. I've been involved in medical research for over 5 years now. So 5 years experience plus of being a patient collaborator involved in a variety of studies, mostly at the University of Exeter, but sometimes Plymouth, and actually nationally and internationally nowadays. Thank you.
Great, thank you both. So it was going to let me, oh, it's frozen for a sec. Great start. So for the first section, we want to talk about what patient public involvement is, and importantly, what it also isn't. Before we actually make a start on this session, I really want to kind of gauge what everyone's understanding of patient and public involvement is. So when you can you use the chat function just to complete this sentence? So patient and public involvement is, I just want to say, don't worry if you haven't come across this term before, or you feel like it might be a bit wrong, your definition. This is really just to see kind of like a starting point that we can build on. So you might want to think of your definition. What do you think about when you think about the terms patient or public? And where do we normally see this word involvement? What does it mean to you? So I'll just give you a minute or two to submit your answers into the comment section. And Lauren, if you can keep a little eye on it, because I've realised with one screen, I can't see any comments. Very helpful. So
Will
just
do.
That. Thank you.
And whilst this is going on, could I just say there's a possibility, because I live in a flat, I get the fire alarm tested remotely. So if I suddenly go on mute and stick my fingers in my ears, it's because the fire alarm's gone off.
Thanks for letting us know, Leon. It's nice to have a little touch of drama into the session. So I think that's enough time for everyone to submit their answers. Lauren, can you see any common themes that are popping up at all?
So there's a lot of comments here about how the role of patients and the public can be integrated into the way that the NHS works. So I'm also seeing making sure that patients and the public are included in decision making, which is really promising. Allowing patients and the public to have a say in how research is performed and what the results are used for, learning from different perspectives, consultation with patients and public groups to inform decisions, future research, about keeping the work that we do relevant to service users, and important to make sure research outcomes are actually relevant to people. So a lot of really good, promising sounding common themes, I think.
That's a fantastic start, to be fair. That's such an amazing starting base to kind of build on today. So I'm really glad to see that people have some kind of basic understanding what patient-public involvement is and even why it's important, which is, again, very promising to see. So to give us a little better idea of what we mean by patient-public involvement, we just have this short little video that was created by the patient-public involvement team, which is only 2 minutes long, gives us a quick little overview of what we mean by it, but also introduces you to the PENPEG, which is the Peninsula Public Engagement Group that Leon mentioned earlier. So,
Georgia, sorry to interrupt. Before you play that video, speaking as a Zoom user, did you enable it so that it's optimized for video? Because I've got a feeling that my settings won't allow it.
Oh no.
Okay, can you? That's fine. If you stop sharing your screen, sorry, otherwise it'll come out as a jumbled mess. So if you stop sharing,
okay.
I will switch the settings my end. Can you remind me before you go to breakout rooms to put this? I need to put this back, otherwise it won't work. Okay, so now if you share your screen again, but select the option, there should be a little tick box that's now enabled that says optimize for video.
Okay. Let me see. Let me just make this big again.
Otherwise, it comes up as a slideshow. You see. So...
Oh God! Okay, it's lucky that I mentioned it now.
I thought I better just
a nice little addition. Okay, so hopefully this will work this time round. But if not, someone give me a little shout if they can't hear or if it doesn't come up properly. So.
We're not getting any sound, Georgia, sorry.
No, it was all going so smoothly. Oh, God.
Did you tick the other box that said share sound as well?
Yes, I believe I did. It's really weird.
Yeah, it's Zoom.
There, I got it. Okay. I am now showing sound. Let's try that again. And I hope
third time lucky.
Yeah.
PPIE is patient and public involvement and engagement. Bringing in the voice and the views and opinions of people who are not researchers but users of services.
Trying to make sure that the research produces answers that are useful to them. We're
really committed in the southwest to PPIE, particularly in Penark. So we involve members of the public, service users, carers, patients, in thinking about what research needs to happen and the way it happens.
And then we meet with researchers, give feedback on research ideas, and work with researchers to provide a kind of patient and public perspective.
PenPeg is our patient engagement group.
From all backgrounds, all areas, ages, professions and everything.
This is a core group of people who are deeply involved in every aspect of our organisation.
We meet and support each other in our PPI activities. It's a way that we can communicate with the PPI team.
Just because someone's an academic doesn't mean to say that they know everything, and I don't say I know everything. If we can mix our ideas together, then perhaps we can change things together.
So the HSMA study is one of my favourite stories. We had the plans for a really big piece of work.
The project really is looking at two ways of doing hip fracture repairs.
There's a standard one that is accepted in this country and an alternative approach that can bring them back to a level of mobility closer as before they fractured.
We had a workshop with patients, and the first thing when they finished their presentation, a carer who was in a group said, "That's all good and well, but none of this is important to me and my mum."
The basis was that actually there's very little research on which way was best.
The surgeon, John Charity, who was going to lead the study, he was just so happy. He was invigorated.
John listened and he came back with a solution to my questions, and I was very excited by the fact that he actually went away and thought, well, how can I make this happen?
It's very interesting to see the insight provided by a PPI representative. I really feel that it does make complete sense because we're studying patients. Clearly, you need someone who will be an advocate for them.
I have to say, it's one of the best things that's ever happened in my research career.
We have made change. I may only be a small tool within a very large cog, but sometimes the ideas that I have can change things for the whole country.
To make the healthcare system better for everybody.
It's the opportunity to perhaps improve the quality of life for hundreds of thousands, if not millions of people. I think it's phenomenal. It's the best thing I've ever done.
Hopefully that was helpful in giving you a little overview. It was quite promising to see that a lot of the things that the video covered was actually some things that we saw in the comment section, which is great. But before we go on, I just want to unpack this just a little bit further. So when we talk about patient and public involvement, we typically follow this definition that was made by the National Institute for Health Research, otherwise known as NIHR. So this idea that research is done with people rather than doing it who, about, or for them. So it's kind of redistributing the power imbalances that we typically see in research. It's about having an active partnership between patients, the public, and the research process. And it's very important to say that it's different from taking a part in the study. We're not trying to extract data for someone and then analyse that data to answer a research question. It's very much about working towards that common goal of conducting and improving research. So to note, just when we're talking about patients and public involvement in research, we typically call the people who are involved in this research as public collaborators. But a lot of the time you might see in the literature that this term changes quite a bit. So it could be otherwise known as experts by experience, or for example, community representatives. In this case, we're going to carry on using the term public collaborators because this is something that we spoke to with our patient and public involvement group. And this is a term that they felt happy with and felt represented them as a group. So again, if you're doing work with the public, I think it's always very important to say, what would you like to be referred as within a paper or within this group? So it's really important when we talk about public involvement to really talk about these different ideas of involvement, engagement, and participation, which quite a lot of the time they're kind of merged into one giant thing when they're actually in fact 3 separate categories. So when we talk about patient and public involvement, we are talking about this definition here of involvement that I've already just mentioned. So it's actively involving research people with lived experience in research projects. For example, it could be identifying research priorities or interviewing participants. Is not collecting data or data extraction, is working within a team. So again, very different from participation, which is what we think about classically when someone is invited to take part in research. So for example, it could be inviting someone to a clinical trial. So again, it's the idea of extracting data with participation to answer a specific research question. We also have this idea of engagement, which fits into the E of patient-public involvement and engagement. So that's the definition here, where information knowledge about research is provided and disseminated. So for example, it could be shared to media outlets, through scientific conferences and things like that. Importantly is also say what involvement is not. So again, another very common misconception is that patient public involvement and qualitative research are exactly the same thing, whilst they are not. To be fair, there are some overlaps in the type of methods they use, but a good way to kind of tell the difference between it is the aims and objectives of trying to use it. So for example, qualitative research is about talking to a participant, whether that's through an interview or focus group, is gathering data and then answering a research question. So that data will then be used and analysed. For example, you might be picking up common themes, again, with the purpose of answering a research question. Whilst on the flip side, patient-public involvement is really about working together in the conduct of research itself. So it's not qualitative research, it's not participation, and importantly, it's not a tick box exercise. We're actually doing this to actually create like almost a mechanism for change, to create service improvement. And a really good development has been that the NIHR now makes it a requirement that when you're applying for funding, you have to say how you're going to involve members of the public in the project. And again, it's been absolutely fantastic. You also need to give justification in cases where you're not. And again, it needs to be a very solid justification. And whilst this has been, again, extremely amazing development, also showing how patient-public involvement has really been seen as something that's essential. At the same time, a lot of people, because of this reason, also see it as an obligation rather than something that actually has such a huge mechanism for change, which is a bit of a shame at the same time. So again, it's trying to recognise that involvement is important and it can lead to so many great outcomes, which Lon will talk about later in this presentation. So hopefully you've been listening to this first little part of the presentation because we really want to try and test your knowledge a little bit. So I'm going to read out a few different scenarios and I want you to consider whether these describe public involvement, whether they're quantitative research or whether they're qualitative research. And I'll read these through, but if you could put what you think it might be in the comment section, that'd be amazing. And then we can just discuss the answers together. So the first scenario is that a team of researchers invite patients to a meeting at the university to discuss a research idea. So if you could use the chat function and tell me, do you think this is quantitative, qualitative, or patient and public involvement? Likewise, if you prefer to actually shout your answer, please feel free to go ahead. I'll just give you a second. Ooh.
So the majority of answers so far are PPI. This is patient and public involvement. We've got one quantitative and a couple of qualitatives.
Right. That's a good little start. And again, I feel like this is really showing the kind of like overlap that you see quite a lot with PPI and qualitative research, because again, the methods are quite similar. But if we think about the underlying objectives, so for this one, is inviting patients for the meeting at the university to discuss a research idea. This would be considered patient and public involvement, because we're talking about that research idea. We're not talking about trying to get information from someone to answer the research question itself. We're still in those early stages where we're talking to people, and we will probably adapt our research idea based on those early conversations. Again, I see why it could be considered qualitative research, because we have those same overlapping methods in that we're trying to talk to a group to gain the perspective. But again, we need to think about the aim, the objective, or why we're talking to these patient members. So moving on to the next scenario, if it will let me. There we go. Scenario 2. A research team is developing a questionnaire as part of an evaluation of a self-management tool for people with diabetes. They're using cognitive interviewing with patients to develop and test the questionnaire. So cognitive interviewing or cognitive testing is a method designed to investigate whether a survey question satisfies its intended purpose. So explain that a bit more, you think about cognitive interviewing to really see whether a question you're asking is actually being interpreted in the right way. So for example, if in a survey a researcher asked a participant to rate their health from a scale of 1 to 5, 1 being poor, 5 being better. Someone who's reading that question might think, oh, perhaps they're talking about physical health, whilst the researcher actually intended to create more of this holistic element of health that covered both mental health and physical. So it's really talk to patients about almost like thinking out loud of what they think this question's asking them. So do we think this is qualitative, quantitative, or public and patient involvement? Again, when you have time, check your answer in the chat.
So far, we have lots of qualitatives and one quantitative so far.
Again, great. Thank you. Again, this one was quite a mean one to be fair, because as I said, the methods of qual and patient and public involvement overlap a lot. But despite the kind of, we almost feel like a little evil bit of saying interviewing in this. And again, as I said, qualitative research and its methods often overlap with patient public involvement. But again, this is an example of
patient properties can be excluded.
Yeah, so in this example, it would be patient and public involvement, because when you think about, we are trying to optimize research in its own way. So we're using these interviews to test out the questionnaire, and we'll see if this is something what we intended to actually ask. So we are asking patients and public members if this is the technique is actually almost fulfilling its purpose, and then we can optimize that research based on the answers. So for example, if they interpret the question not as we intended, we would then alter that research question before sharing it with the participants later in the study. So again, I admit this is a little confusing one, which is quite mean of us as a team to give you. So scenario 3. A research team wants to evaluate a self-management tool for patients with diabetes and uses findings from a systematic review of qualitative research to incorporate the patient perspective. Again, if you can use the voting function.
So we haven't got quite as many responses for this one, but it's quite a mixed bag of qualitative, quantitative, none of these. So, Georgie, tell us the answer.
So again, this is quite an evil scenario to give you, which this one we kind of wanted to open up because it has been a subject of debate. So this is an example of very, very poor patient and public involvement. And the reason we're showing this to you is because we do not want you ever to do this kind of thing. So this is an example that was actually published and was considered an actual example of patient public involvement. Because although they didn't actually speak to members of the public, it was seen as passable because they still incorporate the patient perspective to change the research idea, which again was amazing how it even got approved in this kind of sense. But it has been a subject of very heated debate of whether it should be reconsidered as patient public involvement or qualitative research. So again, that is an evil example, but just to illustrate that we should not be trying to do patient and public involvement in this form, is very much kind of trying to cut corners with this approach. And then lastly, we have one more scenario to give you. Again, there we go. So it's now for a group of researchers are looking to find new ways to learn more about people who are living with more than one long-term health problem, otherwise known as multi-morbidity. So to do this, they use advanced data science and artificial intelligence to develop new ways to bring together new information about people held by different organisations. So the researchers meet with 12 people with lived experience of multi-morbidity to provide feedback on what health conditions the project should focus on and what the research questions should consider. So again, if you can use the little chat function to submit your answers.
This one is a very unanimous PPI from the chat box with one qualitative and PPI.
Great. Well, that's very promising. This is again a very strong example of patient and public involvement. So well done, everyone. So again, it's a meeting with people with lived experience to really determine what the project should look at and what the research question should consider. So it's really given that opportunity for people with lived experience to say, what is important to me? Is this research something that would actually impact me? And is it something that I would deem important myself as a person with lived experience? So well done all. So after that little section, I hope that was very thought-provoking. Again, we had a very mixed kind of selection of scenarios, which was intentionally done in a very evil way to get you thinking a little bit more. So for this next section, we just want to build on the things that we've learned and we go into why we actually do patient-public involvement. So what are the reasons? And for this section, I'm going to pass you on to Lauren, who will be able to tell us a little bit more.
So hi everyone, I'm Lauren. As I already introduced myself, but as Georgie very kindly has put this presentation together, section 2 is going to be about why we do PPI. So why do we do PPI? I would like to direct your attention to the next slide. If Georgie can move it to the next slide. So this photo, what is this photo of, you ask? I'm sure you already know, but let me know in the chat box what you think is wrong with this picture. Yes, it's true. It's missing the clock face. Where's the clock face? So you guys all knew that pretty quickly as well. Oh, and the sky is blue. It's very unrealistic for England, but yes, the answer is that the clock face was missing. So this is a quick exercise on basically the fact that you don't know what you don't know, right? So Big Ben, we have the context and prior knowledge to see that something is wrong straight away because we have the lived experience of, well, being in the UK, right? So let me bring your attention to this photo. What's wrong with this one? Any more answers? Just these two? Oh dear, Georgie, we've got a very astute group with us today because most people do not know that the dome is missing, but lo and behold, the dome was missing. So this is the parliamentary building in Argentina, but usually when we do this exercise, people have no idea what's wrong. Why is it? It's just a normal building. There's nothing wrong with it. And the idea is that, like I said earlier, you don't know what you don't know, right? So the idea behind doing this exercise is that the patients and public have perspectives on areas of health and health research that we as researchers can't always see. And so this exercise was basically to demonstrate that that to anyone who doesn't know that there's supposed to be a dome in the background of this photo would just see a normal building. And so we need the new and fresh perspective of patients and the public to help us see the full picture. So why involve members of the public in in health research rather? So these are the three most commonly cited reasons, but it's certainly not an exhaustive list. So mostly it's because of morals and rights, in the sense that people who are affected by research have a right to get a say in it. Furthermore, public members have the right to have a voice in the public services that they're paying for through tax and labor. And the individual has a right to be involved in research that directly impacts them. Furthermore, recognition of the importance of experiential knowledge alongside scientific understanding is a really good sort of all-encompassing reason as to the moral standing behind the conduct of PPI in health research. So the other reason that was on that slide before this one was the quality of research. Sorry. We want to improve participant recruitment, research outcomes, and research materials. And in doing so, Georgie, next slide, please. PPI improves the quality. Next slide, Georgie. PPI improves the quality within health research, particularly in terms of service delivery and patient outcomes, and it ensures that the research focuses on the outcomes that are the most important to the public, as you all very astutely pointed out in our original question at the start of this presentation. So good job. It improves recruitment and retention of participants by ensuring that the researcher's methods of communication and research are sensitive to the needs, customs, and circumstances of the target population, which I will also be doing a little bit of a section on later on in this presentation. So finally, relevance. This is to ensure that the research is focused on what matters the most to people. And PPI can improve the relevance of research by ensuring that the research focuses on indeed what matters the most to people. For example, public collaborators might help to identify and prioritize research topics, suggest new ideas for research, and help reshape and clarify the research too. So later after this session, Georgie will be sending out a little pack full of, further details and studies in which these sort of three cornerstones of PPI can be seen in real life research. But I am just going to give you a quick anecdote with regards to the relevant section, in that, for example, a public member on a systematic reviews research group that I'm a part of used his own experiences with hearing and vision loss in a proposed systematic review about just hearing loss. But in incorporating his experiences and letting us, the researchers, know that, there is a link between hearing loss and vision loss in some people, we were able to broaden the research question and add more research to our systematic review. So that's just one example of the real life impact that PPI can have on the course of research. But that's enough talking from me for now. We want to sort of get a public member's view on why members of the public get involved in research. And so I'd like to hand you over to Leon so that he can tell us his journey to involvement. And of course, if you have any questions for Leon, please feel free to share these using the chat function, and we'll both be sure to review them so that he can give you some answers. So take it away, Leon.
Thanks, Lauren. So my involvement, my journey to involvement started actually with participation. I joined a pilot study, a pilot intervention with my daughter. It was called MAC, and essentially it was mindfulness-based cognitive therapy for adolescents and carers. So the proposal was, my daughter's mental health was very poor, and it was suggested that we do this intervention where practicing mindfulness would help her through some of these mental health issues. And she took a full course and then the carers, parents or carers, were given a stripped down course so that we could kind of understand what our young people were going through. And I actually found, you know, it gave us opportunities to discuss it and work together on some of these problems, which was an incredible relief for me. I was a single parent and I was at my wit's end. I was so distressed that my young child was hurting and I didn't feel like I could do anything to help her. And then suddenly this intervention showed that it gave me an opportunity to feel like I was being able to help her a little bit. Unfortunately, her social anxiety meant that she didn't complete the course, but I did. I really took to mindfulness. I've got my own mental health issues, depression and anxiety and PTSD. And I actually found the course really helpful and then went on to do an adult course, a full course in my own right for myself. Part of being a participant in the trial, we'd agreed to give feedback at various stages, you know, sort of each week after the next part of the course. But then at 3 months and 6 months and even a year afterwards, sort of follow-ups just to see how we were getting on and whether we had recurrent bouts of depression. Was that one of these? So I was very impressed with the mindfulness and I thought it was an excellent intervention. Working together with a young person made it even more effective in my view. So then after, I think it was about a year afterwards, after we'd completed the course, we were at one of these reunions where we were given feedback and we did a mindfulness session and just sort of had a catch up and fed back. And Kristin, the PPI lead from Pennock, came along with a researcher who invited people to join a study where they wanted, so she wanted to ascertain whether it is in fact effective for young people and whether it's cost effective as well for the NHS. So I kind of jumped at the chance to get involved, partly because, as I say, I thought it was an excellent, effective intervention, and I thought if I could do anything that might help it get developed and rolled out across the country and sort of improve young people's lives, or you know, masses of young people's lives, I was all up for it. I've maintained a keen interest in science all my life, and so yeah. And whenever I've gone to the doctor and they've said, "Oh, we've got a trainee, do you mind if the trainee sort of deals with you?" I'll be sitting in the background. I've always said yes. I've always wanted to encourage the education of our new medics. So it seemed like a no-brainer to me to get involved. And after a couple of meetings, I mean, I was finding it really, really valuable. It was clear that we had some useful things to say. There was a group of about 4 or 5 of us, parents and young people, helping to advise on the study. And you know, it became quite apparent that there's a lot of areas that we could cover and actually offer our wisdom to. We then asked if anyone would like to become a co-applicant. And again, because I was enjoying it so much and really felt like it was a very worthwhile thing to do, I volunteered to become a co-applicant, which meant that I helped very much in the construction of the protocol for the bid for funding. And so, and my name's on the funding bid, etc. And so that was really, really good for me to see I was there right at the beginning, really, and I managed to help to shape the study right from the get-go, really, which was very satisfying. Unfortunately, we weren't successful in the bid, so everything went quiet for a while, and then I had a stroke, and then we returned to the bid after about a year, we put forward a new bid where we decided we'd just run a pilot study of the main bid that we were trying for ultimately. And we did get funding for that, fortunately. So that went ahead over a couple of years. But by then I'd become known to the PPI team at Exeter. And since I'd had a stroke, I suddenly got offered another couple of studies to work on that were related to stroke. And again, one of them I was a co-applicant on, and the other I was not co-applicant, but a member of the management team. And I guess it just took off from there, really. And nowadays I'm working on quite a large number of various studies. Apart from my mental health issues and the stroke, I've got multiple long-term conditions as well. So those are the areas that I kind of focus on, and different strokes, those different aspects for the different studies. I feel like I've been really quite fortunate in that on most of the studies, I am actually a co-applicant and or management team member. And for me, this is the most rewarding kind of involvement. I'm often in right at the very beginning. I can help shape the protocol itself and carry on shaping the study as we run it. And by being involved and by going to the regular management meetings, I sort of get kind of very direct feedback that so it's very easy for me to see that if I've made a contribution that's been taken up and used, I can really see that I have had an effect and maybe made, some kind of valuable contribution towards the study. So this, I just find it so inspiring. I think I said in the video, sorry about having videos of me and things, but it is the most rewarding thing I've done in my life. If I can, if I can in my small way do something that could potentially help millions of people, this is the best thing ever. It's the most worthwhile thing I've ever done. So I do feel very inspired about involvement. Sort of back in the early days, once I'd started on the stroke, so I guess it was about 2 years, my second year of being involved, I did some training, and those photographs that we saw earlier, that was part of a particular training course I went on. And that was fascinating. It just gave me the confidence that we can, as members of patients or public, we do have a different perspective, and we sometimes know something that a researcher doesn't know, just because we've got the experiential knowledge of it. And it kind of gave me the confidence to speak up a bit more, and I am quite shy. But to just having the confidence to know that actually one's opinions can really be valued and help to shape the research, which is fantastic. I was going to say a bit about, that's kind of good involvement, for me, that means being quite heavily involved, you know, from the beginning, if possible, and a regular involvement. For involvement, we said that PPIE is not a tick box exercise. I mean, the NIHR and I think all health bodies now insist on PPIE if they're going to fund a study, and I think it's becoming less so, but there's still on occasion you'll find a researcher who is just tick the box and said, yeah, we'll get someone in because we have to, and it becomes very, very apparent, you know, whether a researcher is on board and it actually values PPI or not. So again, that takes it back to what is good involvement. Good involvement is where the researcher gets it. You can easily tell, you know, a researcher gets it. They actually want the PPIE, and they realise that it can be a real valuable contribution to their studies and their research, and so that would make for good PPIE, really. I mean, occasionally, you know, you on the other side of things, you can maybe just be invited to a focus group. It might be a one-off, or you might not hear anything for 6 or 8 months, and then you might get invited back for another one, and you haven't had any communication in between. You don't know really what's happening. You don't know if you made a difference at all. So yeah, to really get good PPIE, I think you've got to be behind it. You've got to see the point of it, understand the point of it, and sorry, I'm looking at this question now.
It's fine. Just mindful we have something in the chat here. So we have a question here for Leon. So where do you see PPIE making a contribution to analytical work, not just research?
Well, I'm not quite sure what you mean by that, but by analytical work, do you mean sort of like big data, or?
Would you be, sorry, I can't see the name on here, but would you be happy to talk about your question a little bit more with us so we can get a better understanding of what you're trying to ask? I'll just stop sharing my screen for a minute so we can all actually see each other. That would always be helpful. There we go.
Hi, my name is Sigal, and I work with an improvement team in my hospital. So we do work quite closely with patient and public involvement group on all the improvement projects. But when it comes to doing my analytical work, where does it fit in? So yes, it goes into designing the project, but in terms of the analytics themselves, which is, so I think most of the people on this course are analysts of some description rather than researchers. So how would I use public and patient involvement in my work specifically? So, because I just see numbers basically, but I would like to know better, but I don't quite know how. So right. I guess.
Okay, yeah, I mean, I do think there's a contribution that can be made. The first stroke study I started on was basically an interrogation of half a dozen databases from across the world, and we were looking at if you know, birth defects, thalidomide, accidents, veterans having amputations. If you can't have your blood pressure taken on your arm for any reason, we ask the question, can we take blood pressure on the leg instead, at the ankle? And so we compared these databases where they had taken both arm and leg readings, and we've worked out a system where we've worked out statistical modeling so that we've come up now that we've got a very accurate figure that if someone wants to take a leg blood pressure, they can just take that reading, and we've got a calculator and an app that converts that automatically to the what the arm blood pressure would be. So this is very important, you know, for people for sort of helping to prevent, you know, further cardiac sort of events. So very statistical, but then because I'm on the team meetings, I'm on the management team, so we'd go to a meeting, our statistician would come and sort of lay out the work that they'd done. So I guess this is kind of, I hope I'm talking to what you're asking. So the very analytical side. And we went through the figures as we were beginning to get our results. And we were taking the highest arm blood pressure and the lowest leg blood pressure. So I asked a very naive, simple question: why are we taking the lowest blood pressure on the leg and not the highest? And then one of the clinicians came in and said, yeah, that's a great question, Leon. I was going to ask that myself. And in fact, you know, if I refer you back to a previous study that I've done, it shows that, you know, you should be perhaps taking the higher leg blood pressure. So yeah, just having sometimes a really naive, open sort of question can really affect even the analytical side of things. That researcher, the principal investigator in this study, is he's one of the guys. He's one of the good guys. He really values PPIE, and I mean, he's actually, you know, said. I mean, it's so refreshing that if a member of the public can ask questions of our statistician, which I've been wondering about, because I mean, he's a GP. I mean, he doesn't know all these involved statistics either. So, but by having a patient there, it's perhaps easier to ask those simple questions, which then forces the statistician to talk at a level that everyone can understand. So yeah, I think it can be really valuable. I'm working on another study, another stroke study, which is all involving AI, machine learning and modeling. Again, yes, yeah, I think there's space for input even in the most analytical studies.
Fabulous, thank you so much.
Thanks, Leon. I just want to add to that a little bit, because I think you touched on so many important things there, both in terms of inviting people to management meetings where you're more likely to have that patient perspective consistently, and also being able to, in those meetings, that actually raise those important questions that might not have even been a conversation before. But it's also, like you said, recognizing the importance of the patient voice and how this can contribute. So it reminded me of a study I'm involved with that is looking at a big data set, the CPRD, so the Clinical Practice Research Database. And we're trying to look at levels of self-harm and mental health diagnoses amongst children and young people during COVID and before, and comparing these levels. It was really important to involve people who work with this population. So for example, we put together a group of people who are more likely to work with children with mental health problems, whether that's teachers, psychiatrists, psychologists, support workers. And then we presented the database to them to help us understand it a bit more. I think that was really important. So for example, we saw a really quite significant increase in a certain mental health condition that even COVID couldn't quite explain. So we presented this to the group and said, we don't really understand this. We don't know why we're seeing this trends, because again, we're looking at a data set. We don't know what's behind this in any kind of way. And then some of the experts, they were able to say, have you thought about this has been a change in the way that we code things in the database? So in that case, this mental health diagnosis was actually grouped with another. So again, we're seeing these giant increases, and without that knowledge of that expert stakeholder group of experts, we would have no idea that there was something else to play behind it, whether that's just a change in a computer system more than anything. So again, I think very important to involve people in these kind of conversations, like Leon said, whether that's in a management board meeting, whether that's creating an independent group to talk about these types of data that we're looking at, or even the preliminary findings, is just always having that kind of thing in the back of your mind. Dan, I see you've got your hand up there.
Yeah, sorry. Thank you, George. I was just going to chip in actually, just to say, reminded a little bit of a piece of research work that I did many years ago, working closely with the patient involvement group, and that was around polypharmacy and trying to basically build a simulation model to try and understand why people don't take all their sort of medication as prescribed, and it was a real eye-opener. The heart of that project was in terms of the patient involvement, because all the literature up to that point talked about compliance. Why aren't these patients complying? We've prescribed them this medication. Why aren't they taking it? And the whole thing was about, well, how do we increase compliance? And it was all very much focused around that. And actually there was the gradual sea change, and talking to the patients who have multiple conditions taking multiple medication, because you look at that as somebody that doesn't have multiple conditions, you think, well, why wouldn't you take all your medications as prescribed? Well, I don't understand. But actually speaking to people and understanding, well, yeah, it's because I've got all these different things, and if I take these things together, I feel absolutely rubbish, and my quality of life is terrible. And actually, the whole purpose of that project was to try and look at developing a proof of concept model, that agent-based simulation, actually, that would try and understand, well, okay, maybe what's the point of prescribing things that are the most clinically effective if people aren't taking it, and the majority of people aren't taking those medications. But actually, by listening to people, can we find a sort of common ground that actually says, well, actually, if we prescribe things this way, it will reduce the okay, it's not quite as clinically effective, but if people are more likely to take it and have fewer sort of adverse reactions, then surely that's a win, because people are just are suffering because they're not taking their medication, because they feel like they can't win. And having that patient voice, and we had a sort of entire team that we would talk to about this kind of stuff, and it was so eye-opening to find out sort of the real causal reasons why people weren't doing it. So I think it's very easy for us, as particularly sort of modelers and analytical type people, to look at the numbers and think, well, that doesn't make sense. I think I mentioned earlier in the course about the example of a piece of work many moons ago that we did in Pencord, that was looking at a geographic model. Where should we place our clinics? And nobody could understand why everyone was driving past the door of hospitals that offered the services they needed, and they were all going to Barnstable. And it was only when they started talking to the patients that they identified, oh, it's because people like going to shop in Barnstable, because they think, well, if I'm out for the day, I'll go and do a bit of shopping. And if they hadn't sort of identified that, they would just thought, oh, there's some sort of weird, all we need to do is this, without actually speaking to the patient and finding out why they're sort of behaving that way, why they're doing those things that just looking at the numbers just doesn't show us. So I think it's for me, that kind of stuff just shows how important it is getting that sort of patient voice in there.
Yeah, that's such a good example. Leon, did you want to add to that as you got your hand up as well?
Yeah, have we got a minute? If I could expand on the AI machine learning study, if that's okay. Part of the protocol was that we would make explainable AI and machine learning. The study, I'll be talking about the study a bit later, but essentially we're looking to improve rates of thrombolysis nationally. The current rates are about 12%, and NHS recommendations are for 20%. And so there's many reasons why particular stroke units don't thrombolyze patients. So we've constructed these machine learning models that we can model every hospital, every stroke department. We can model their particular pathway. We can look at time arrival, time of onset, etc., and really get down into the detail of which patients should be offered thrombolysis, and sort of find out which aren't. There's some very low performing hospitals nationally, and one of the things that hospitals often say, oh yes, but our patients are different. We've got particularly different circumstances. So yeah, we don't talk to us about it. We're unique, we're unusual. So we're finding with machine learning models, that we can actually circumvent that sort of attitude and actually just lay it down to them in black and white. Look, this is the modeling. But so the study does very much entail looking at how we can give clinicians in the stroke pathway the confidence that the modeling that we're doing is actually very cogent, it's very correct. And I mean, so there's still, I guess AI machine learning is still quite new to a lot of people. And so there is some reluctance maybe to accept the findings. So we're finding that if we can explain what we're doing to our public group, our group of patients and public, if we can get it down to such a easy example, then we'll much more readily be able to approach the physicians. Then once we've got all the details, we've got the app for them, we'll be able to increase their confidence as well. But it's only through working with the public and patients that we managed to synthesize it down to its simplest and most understandable form.
Great, thank you, Leon. Those are really nice kind of case examples of the importance of it. I realise that we're getting on with time so quickly, it's already 2:30, so I'm just going to reshare my slides for a second. If let's make it big. So I just want to say, if anyone has any questions as we go through, again, please feel free to put in the chat. And if you have any additional questions of Leon, what we're going to do is compile the questions we couldn't answer in the section, and then send out a document afterwards that we've had time to revise the questions and give our responses to. So just keep that in mind. But before we go on a short break, we just have one final activity to talk about this type of things that we've covered in this part of the section. So we want to, we would like you to read this case study and consider a few questions. So who would you like to hear from? Why would you like to hear from them? And how would you ensure they're able to share their views? And I mean this within a patient and public involvement perspective. So in terms of the case study, this is a real life example of a study that's ongoing at the University of Sheffield. So a group of researchers are interested in people with several different health conditions at the same time, as well as people who are frail or vulnerable. These people may need more help and support than people without multiple health conditions, and could be better helped if we understood which health conditions affect particular people, how their health has changed over time, and how they currently get help from health and social care services for their health problems. So this information already exists, but in many different places. For example, in doctor surgeries, clinics, and council services. The different organisations involved don't always have a way or the time to talk to each other. So to overcome this, a team of data scientists and clinicians aim to develop new ways of bringing together new information about people held by different organisations, and develop new ways for computers to do this. So the methods to be used are called advanced data science and artificial intelligence. So with this case study in mind, we would like to put you in breakout rooms to really think about who would you like to hear from. So whose perspective is really important to gain here in terms of patient and public involvement. And why is it actually important to hear from them? So what could we achieve from involving this person? And lastly, how would you ensure that they're actually able to share their views? So for example, what type of activities would you put in place? What you might need to consider to make this activity actually accessible for that person. So as I said, we won't put you in breakout rooms for this activity and then report back as a group. So when you're in these groups, again, I would like you to talk about these activities. Lauren will put a little PDF into the chat, which contains this case study. We're not expecting you to remember any of that I just covered. But then we would really like to come back as a group. If you can nominate one person from your group to feedback, that'd be absolutely fantastic. It's up to you whether you'd like to actually verbally feedback and put yourself off mute, or you have the other option of actually submitting your answers into the chat. So for this bit, we'd like to put you in groups for about 10 minutes, and then we'll feed back. And Lauren, Leon and I will just float around the groups just to check in to make sure we all have an understanding. Before I put us into the groups, does anyone have any questions about this activity at all? No, I think we're looking okay. So, like I said, I'll just post all into breakout rooms now. They should all be open. So when you have the link to join them, please feel free to move over to the breakout room.
George, I was just going to say as well, if you want to, you or Lauren want to share the PDF, I'll put it in the Slack tannoy as well, so that people have got it there as well.
Oh, that'd be fantastic. I'll send it over to you now.
Brilliant, thank you.
It doesn't seem to be an option to actually insert PDFs into the chat box, so...
Oh yeah, I don't think you can on Zoom like you can with Teams. Have you got, if you can put it on, actually, are you on Slack? Are you logged into Slack at the moment?
I believe so.
If you go into the HSMA tannoy, you should be able to just drag and drop that PDF file into the chat box, and it should upload it.
Excellent. Let me see if I can get into the Slack. Thank you.
No problem.
Do we have everyone back with us? That is the question. Hello, Lauren and Leon. Okay, I think I'll share my screen. Ready? Oh, we have a thumbs up. Okay, we have life. We're good. Okay, multiple thumbs. Thanks, everyone. Okay, I'll just share my screen again in that case. To make the setup properly. Select me. There we go. Okay, can everyone see my screen and hear me okay?
Yes.
Looking all right? Fantastic. Thank you. So for this last little section, we kind of want to discuss how do we practically do patient public involvement, because again, we spoke about the whys, we spoke about the hows, but how can you actually apply this to your own project? So it's kind of important to recognise where PPI actually fits into research. And a kind of neat way of trying to think about it is mapping it on to this research cycle. So, for example, identifying, prioritising, commissioning, designing, managing, undertaking, disseminating, implementing, and evaluating impact. So it's really important to note here that in best practice, we really do want to involve patients from the onset, from the very earliest stages. For example, even when you have a newly formed, even a half-formed idea, it's really good that get that patient perspective in then, so you can kind of alter your research and there's a much bigger scope for change. So just to talk about these stages of research a little bit more and where PPI kind of fits into it. So in terms of identifying and prioritising, so PPI can help ensure that the research aligns with what is most important to patients and service users. So it's really thinking, is your research focusing on what's important, and have you missed out anything important? A real neat example of a project that's involved patient public members in this stage is this project called CAMS Rise. And it's such a beautiful project where basically a group of researchers invited young people who'd had experience with CAMS to prioritise a bunch of research questions. And then whichever research questions were prioritised were then brought forward and given to a group of trainee clinical psychologists who could actually then research those questions that the young people picked out and thought were most important to them. So that's just one example of the kind of impact we can have for that. Then we have commissioning. So this is where public collaborators can share issues that are important to them. So a common way of trying to achieve this is through different groups where they can have more of a governing function. So for example, in steering groups. And we'll talk about, I realise that I'm talking a lot about all these different types of groups, whether there's a steering group or advisory group. And I just want to say in the next few slides, we will explain the differences between all of these. So we can often also involve them in designing and managing. So this is where we help ensure that the research methods are sensitive to the needs, customs and circumstances of the population. So for example, it could be reviewing a topic guide in an interview. So by that I mean a topic guide is an outline of what you try to, what you plan to ask participants. So it'd be really helpful to show this to people with lived experience, make sure even the terminology that they use is not something offensive, not that you'd ever plan to, but again, you wouldn't know until you speak to someone with lived experience. Or it could be, for example, reviewing a survey. And a good example is a project that's a feasibility study looking at how to improve physical activity in young people with cystic fibrosis. So for this, we try to monitor the change in how they'd improved over different intervals using the same survey. And we put together a group of children and parents of people with cystic fibrosis, and it was extremely helpful. So in this meeting, we showed them the survey and went through the questions, and they raised a lot of issues that helped us improve it. So for example, the survey length to begin with, if we expect a young person to fill this out, are they actually going to want to sit there and fill out a giant 6-page survey? Presumably not. Again, it's the language using it. It was even things like monitoring medication. And although they said that with the parent support of the young person themselves, they felt very able to say what medication they took in terms of help managing the cystic fibrosis. But things like pain medication, such as ibuprofen and paracetamol, there's not something that you can really reflect back on the past, for example, in the past 3 months, looking back and thinking, when did I use that? So we had in kind of retaliation to that, we created a little reminder type of tally card that could help them then report what medication you use over those intervals to kind of reduce cognitive bias or memory bias. So again, it was really helpful to have these conversations to improve design and management of these type of things. That's we have undertaken. By this, I mean public collaborators can actually be involved in data collection or data analysis. For example, as a role of a peer researcher. So some studies have found that having a peer researcher, for example, in interviewing participants can be really helpful because they facilitate better conversations as they understand what that person's gone through, something that the researcher might not have experience of. So again, it just makes them more open to share their views than what might be for the researcher. Then we have disseminating. So this is where public collaborators can help share the results with their own networks. And they can really make sure that information is disseminated in appropriate format. So that means making sure that is written in plain English, that's accessible for the people that should be able to view this information. So they could include activities such as co-writing a blog post to make sure, again, it's in format so that someone feels comfortable with and is written in an accessible way. And we have implementing. So public collaborators can help ensure research leads to action by establishing a relationship with key stakeholders and then inviting the research team to meet with them. And lastly, something quite important as evaluating impact. And I mean that in the context of patient-public involvement. So we really want to know what has worked well when we've involved people using these certain methods. And there's so many different approaches to impact monitoring. There has been a bit of a debate about what is the correct tool, although I think the consensus is that there is none. So you can use existing measures such as GRIP, which is the Guidance for Reporting Involvement of Patients in the Public, and the Public Involvement Impact Assessment Framework, which can be really helpful in terms of reporting the impact of PPI. But equally, it's important to actually involve patients and public members in evaluating impact. So, for example, did the public collaborate actually gain some from this experience? Did they find it enjoyable? Was it an activity that actually made them feel able to express their views? And then with that feedback, we can alter future activities. So it's really, really important in terms of service improvement. So we've already kind of touched on this of how we should actually involve them. But a real nice way of trying to organise it is in this example of a Gantt chart here. So we'll have some activities planned for the research itself in terms of when we would like to collect data or analyse it. And it's really helpful to map out your patient-public involvement activities alongside the planned activities. So if ever in doubt, I think something really important to think about when considering when to involve patient public members is really to think whenever there's a decision to be made, a patient should be involved in that decision. It should be a collaborative process, as I've said before. We talked about when, but how do we actually go about inviting people to be involved in research? I think before you even go about inviting someone, you need to be really clear about what you're actually asking those people to be involved with. So what is the activity that person will actually take part in? You need to define the role, the time commitment. For example, is this a one-off involvement activity? Do you expect quarterly meetings, or is this something where you'd like them to have more involvement, where they could analyse the data or have the role of peer researcher? And also it's important to think about a form of reimbursement. So how are you going to thank them for their time? And something that's quite helpful is to look at the PNARC payment policy. That gives you a little insight to what we think that is an acceptable rate of payment for public collaborators. So in terms of actually inviting people to be involved, after you've initially thought about the type of activities and the actual role that you're inviting someone to be involved with, this doesn't mean that you need to start from scratch entirely. You need to create a completely new group and invite people to be involved, but you can actually make the most of the connections you might already have, or make the most of groups that might already exist. So for example, you could connect with local support groups, charities and community groups that might have overlapping interests with your research. You could use existing contacts, for example, whether that's someone who's approached you and was interested in your study. You can advertise on social media, which again makes it more likely that you'll reach out to that target group. You can approach schools and colleges, but also it's important to note that there are existing involvement groups and networks out there. So for example, EPIC-PF is a experts by experience group of people with lived experience of pulmonary fibrosis. And they come together to work specifically on involvement work centered around pulmonary fibrosis research. They have PENPEG, as mentioned before, which is a Peninsula Public Engagement Group. And also the Cancer Research Patient Involvement Network exists. These are just a few examples. There's so many more involvement groups out there as well. And these are just some very basic examples of the type of posters that we might leave in community centres or share online. Again, it's very, very simple. As I said before, just giving an overview of the project, the type of commitment they would have to give. So for example, what would your role involve? So it could be a certain amount of meetings, and also being very clear beforehand about the form of reimbursement that you're able to offer them. So now that you have your group together, how would you actually go about talking about the research and involving them in this process? And it's quite interesting, there's so many different ways that you can do this. And there's no one size fits all method of PPI. It's important to note that it will very much change the population you're talking to. So one of the most common examples, I think, is a workshop or an advisory group. And by this, I mean a group of patients come together in a meeting to discuss a certain topic in research. So for example, at the moment we have an advisory group that's come together to talk about a new funding application. And they were involved in the stage 1 bid, but now it's successfully progressed to stage 2. So that means successful in the third stage, and now we're being invited to create a full application. So we put together this workshop advisory group where we can talk about what we've changed in stage 1. And we want to talk, ask the group, is this acceptable? Is this something that you imagined it looking like? And also problem solve some issues and even actually plan future activities. So for example, on this stage, we would like to talk to the group about how they would like patient public involvement to actually look in the study itself. And there's almost having involvement on involvement, which is great. On the other hand, we have one-off or drop-in involvement activities that can be quite useful for people who might not be able to commit to long-term involvement or live more chaotic lives where you might not be able to see them again long-term. So quite a nice example of this was using these kind of involvement techniques with quite sensitive topics, which sometimes sounds counterproductive because again, you'd expect to build up a relationship and talk about it. But again, it's just one approach. So for example, a bunch of researchers were looking at smoking cessation amongst young parents. And they had a young parenting group in a community centre. Here they put up a giant A3 paper and a bunch of sticky notes, and it just said, what are the biggest challenges to stopping smoking? And with that, they just put up the feedback on these sticky notes. There was no need to talk to someone about it at all. It was just giving that immediate feedback, but also offering the opportunity for them to be involved. So just underneath, they were just saying a contact number if you'd actually like to talk through your ideas. But again, it was such a powerful and easy tool to get feedback, and that then impact the study. Then we have something that I mentioned before, so it's a review and study material. Again, this could be a one-off involvement opportunity where you could send study material to perhaps an involvement group such as PenPeg, who might look at, example, your plain English summary to actually make sure this is indeed written in plain English. And although researchers often try to write in a language that's accessible, a lot of the time it is not in any way. So it's very important to have these kind of conversations with members of the public, just to alter the language and gain feedback. Then we have, on the flip side, we kind of have a more intense role of a co-applicant that we've kind of spoken about a little bit before, but this is basically when a person is involved in developing a funded application. And if it is funded, the person has some responsibility in terms of the management and delivery of the study. Next, we have dissemination. So that could be helping share the study's findings, whether that's helping present them at a conference, for example. And then we have this thing called PPI cafes that we'll talk about later. But to just give you a brief idea of what it means, it's these sessions where researchers can sign up to and talk to a public engagement group about an early research idea. And again, it's those very early stages when you have a conversation about it, and it might mean that the patient members could say something that you might have overlooked. They might have suggestions of how you can improve, or even give you ideas of what to actually investigate. As I said before, we have lots of different types of meetings. I think it'd be really helpful just go over the different types so we can see the difference between them. Because again, I don't want to be throwing around these different group names without any context. So first we have this idea of an advisory group. So this is a group of people with lived experience who come together to address a specific question related to the research project. Quite similarly, we have a stakeholder group. So like the advisor group, this is a group of experts, but these are people who are clinicians, researchers, healthcare professionals with expertise in the research topic rather than lived experience. Then we have a project management group. So this includes individuals who are actually responsible for the day-to-day management of the research project. So this can include members of the core research team. So we're talking about your principal investigator, researcher, statistician, project manager, but also ideally we would want to involve a public collaborator in these meetings, and ideally two for best practice. Lastly, we have a steering group. So this provides overall supervision for a trial or research. So they really monitor how the study's progressing and conduct and advise on scientific credibility. So this group should really include members who are independent investigators, funders and sponsors. And again, a public collaborator should be in this group. In terms of planning the meeting, as I said before, we always need to be very clear about the outcomes that we're trying to achieve and ensure the meeting and plan is really centered around this. We don't want to have this tokenistic involvement where we know we should involve patient and public members, so we're involving them in this meeting with no purpose. What we really want to do is create a targeted outcome. What do we want to gain from this? What could potentially change in the project due to the feedback in this meeting? And after we thought about this, we really consider the practicalities of setting this up. So for example, the meeting location, is it accessible by public transport? And if so, will you be able to fund people's travel to actually come to these meetings? Because we never want somebody to be out of pocket for being involved in this kind of work. When you think about the accessibility of the room, are accessible toilets on the same floor? Is there lift access? Again, we typically work in health and social research where people might have multi-mobilities or disabilities generally. So we really need to think about these aspects around it. And also ask the public collaborator, is there anything we should be aware of that could help us facilitate this? We think about organisational barriers. So is the time and location of the meeting appropriate for this group? So for example, as I said before, we involved a stakeholder group in helping us understand some data surrounding young people's mental health. And would it really be appropriate to try and bring this group together during teaching hours? The likelihood is that no one will be able to attend. So again, it's just being very mindful of those very simple practical elements that will really make it sure that these meetings are accessible. And lastly, is additional responsibilities of public collaborators. So do they have any extra care responsibilities as a parent or carer? And if so, can you offer anything to help? Whether that's if it's a study looking at that is involving parents, for example, would you be able to offer a space where they could bring the children or offer childcare? Is again, just making sure that these meetings are accessible for the group. But with that being said, again, there's no one size fits all model of patient public involvement. These were just some simple, commonly used techniques. And patient public involvement should be really flexible and reactive to the needs of the collaborator. So to really illustrate this, we want to talk about 2 different case studies. So firstly, I'll give the example of things I'm involved with at the moment. So is methods of involving people with experience of homelessness and research. So to give you a very broad overview, and this project is an evaluation of a team called the One Mental Health Team, which is hosted at CoLab in Exeter. So CoLab is a wellbeing centre, and the One Mental Health Team is based here. And basically, the idea of the One Mental Health Team is create almost like there's one-stop shop for people who might have mental health challenges. So, for example, and within the team, they have a psychiatrist, a psychologist, a GP that specialises in supporting people with experience of homelessness, and also we have a social wellbeing team. So again, this idea that you can go there and you have this kind of a holistic approach to health. So the overarching aim really is to help improve the response to mental health challenges for vulnerable people. And by that, I mean people who are homeless, vulnerably housed, or experiencing complex needs. And again, traditional models of patient public involvement might not work here. So we try to really establish like building up relationships, and that was very much a priority. So this involved something called embedded patient and public involvement. So essentially, this is a very fancy term for something very simple. So essentially, I volunteered at CoLab on a weekly basis. So people who were using those services could get to know me. They could recognize me. And then after building up that initial relationship, we could have informal conversations about research, which again was very helpful, because when you think about research without any prior knowledge, you typically do think of someone in a lab coat who's coming around and prodding you on the arm, which again, we want to kind of take away that false image. And then after this image is kind of recreated, that's when we can involve people in research and invite them. And again, offer flexible involvement opportunities that work with them. So that's one example, but now I'm going to pass you on to Leon, who can tell us a little bit more about a project called Samuel 2. So Leon, if you would like to take it away.
Thank you. Yeah, so Samuel 2, I've mentioned previously. It's a very interesting study and kind of up your guys' line, I guess, working with AI and machine learning. So this is a national study. So we're looking at every stroke centre in England. And as I mentioned before, there's the obvious considerations when looking at stroke that between rural and urban areas with travel times, etc. But there's also this, we find a very common comment is that, oh, our patients are different to everyone else's. I should go back a bit first, actually. This has been a slight departure in normal practice, in that normally, as a patient or a public collaborator, that I get involved with a study, but there would be a member of the PennArc PPI team also on that study, sort of facilitating and managing the patient public side of things. But on this study, I was asked whether I would step up and take on the role of PPI lead myself. And after some consideration, I decided I would like to try that. So it's kind of, I'm effectively managing the PPI on this study on a day-to-day basis. And then I've got a member of the PPI team who's kind of my line manager in the background, if should I need them. So I perhaps have taken a slightly different approach to the normal approach. First of all, the considerations of rural against urban, and this suggestion that our patients are very different. You know, you can't lump us in and consider us with everyone else. I felt it was really important to get a nice range of collaborators in the advisory group, you know, that were in different areas. So I took my cue from the fact that although predominantly the studies being run here at Exeter and very much led by Exeter, we are collaborating with colleagues from universities of Oxford and Northumbria. So I took that as my cue to make sure that I kind of insisted to myself that I needed to include patients from both those other areas as well. Because, oh, sorry, there's the alarm going. Sorry about that. Yeah, oh, where was I? So being a stroke survivor, it seemed to me, you know, I had an in with all the, I mean, the Stroke Association runs support groups all across the country, and well, I found other support groups that weren't actually, you know, maybe they were a hospital support group rather than the Stroke Association. But that's the avenue I chose to approach and find members for the group, the advisory group. I mean, I guess if there was any advantage from the pandemic, it is that people have become much more familiar with Zoom. And so again, you know, just being able to use that opportunity and think, oh, that's great. I can have someone from Oxford. I can have someone from Newcastle because we can meet together on Zoom. So that opens up that the possibilities for that group to be sort of from a much wider area, more encompassing. So then I formed a group, and I hadn't quite got the full numbers when the study started, when we actually kicked off, and my line manager at the time suggested that maybe I should hold an initial meeting, even if it wasn't for the whole group. But I was kind of resistant to that idea. I think I've already said how, you know, it's much more satisfying if you actually feel like you're in the loop, if you're being communicated with and you know what's going on when. And it seemed to me a bit silly to start off and then maybe get another couple of people in and then almost have to repeat ourselves and go over it again. So I kind of resisted the idea of rushing in until I had the full group. And then the initial meeting was very much introductory. So I allowed, you know, half an hour to do like a team building exercise, which just gave people a chance to start to talk together, researchers and patients and public. And then after we'd had that sort of time to start to form the group, we sort of went on to a nice sort of high level overview of the whole study. And one of the researchers commentated afterwards that they were kind of surprised I'd taken so much time for people to introduce themselves. And, you know, she said, well, as researchers, we tend to worry about spending too much time doing that because we think we might be wasting the people's time. So again, I was quite resistant to that. I do feel it's really important to build a really coherent group. I mean, one thing to be aware of if you're getting people in is that, you know, people may often be describing some really quite personal details, and some things can be really quite upsetting. So for me, I felt it was really important that we had a kind of a really coherent group, and so you can generate an element of trust, perhaps, which is going to help people in their sharing and feel more comfortable sharing. I think that's something important that you should be aware of, and also to consider that, yeah, I mean, at the end of a meeting, someone might have shared something, you know, which is really personal, really upsetting, and you know, you should be aware of that, and maybe you need to go up to them afterwards and say, oh, well, you know, however you do it, thank you for sharing. Is there anything, are you okay? Do you need a bit of support with this? So yeah, finding support groups, other groups to be able to recruit your centre. And then, I mean, I've been really pleased with this group, because I think by taking that time, I think we have got a really coherent group. And I mean, I kind of insist that I won't have meetings unless the whole group can attend. You know, it seems silly to me that you keep leaving people out, and I mean, to get the real benefit of the group, I think it's working really well that we've got a group and we all come at each time. We know each other a bit, you know, so we're happy sharing it with each other. And so just a few things to consider there.
Thank you, Leon. That was a really nice example. Again, I think you raised a lot of important points in terms of what to consider. So everyone just let me change the slide. Oh, slightly frozen. So now I'm going to pass you on to Lauren, who can tell us a little bit about some practical considerations.
Hello again, everyone. So practical considerations to consider when using and doing PPI, as you can see here, are under these bullet points, but the first one is about payments and reimbursement. The slide didn't change. There we go. So payments for time and expertise is considered to be best practice, and it's really important to form a clear payment and reimbursement policy before any involvement activity takes place. It's also really important that public collaborators should be reimbursed for any travel, accommodation, and any sustenance costs, because at the end of the day, they are giving us their time to be involved in the research, and you know, there's nothing to say that they have to do that. So generally speaking, what we do at PennArc is we will reimburse them for, you know, travel costs, how they get to in-person meetings and workshops. But if they take place online, then there'll be a set amount of money to cover the Wi-Fi or broadband that they use to get in touch with us as well. And then the actual involvement we pay them for as well, depending on how long or how much preparation is required for their involvement. So as it says at the bottom of that box, please do feel free to view the PennArc payment policy for recommended payment rates for various involvement activities at your leisure. But the next one is to have a single point of contact. This is really important, and it is best practice to have just one point of contact who will work with the public collaborators on a particular project to reduce confusion, but also to build rapport. Indeed, this will benefit both the research itself by ensuring PPI norms and values are upheld, and it will also benefit public collaborators by providing consistency of communication. And it's also just a lot easier to just have one single point of contact as a public member than having a bunch of different people in different places that you need to contact for a particular research project that you're on. So thirdly is technical jargon. Advisory group meetings should be both enjoyable and accessible to the public collaborators attending the meeting. And so a really good effort on the part of the researchers should be made to avoid any technical jargon, which might hinder meaningful involvement. And this also, and really strongly, includes the use of acronyms. I can see that Georgie is grinning there, because Researchers love a good acronym. There are so many. I don't even know what most of them mean. So it's just really good practice to not bombard public members with them, because if even people within an organization or within research don't know what all of the acronyms mean, then chances are that the public members may not either. But this also comes into effective communication, which is the next practical consideration to take into account, in that it's really important to create a welcoming environment which will aid positive working relationships. And furthermore, continuous communication is essential to ensure engagement throughout the research process, for example, through regular email updates or newsletters, or just opportunities to keep people informed and in the loop. One of the greatest criticisms or critiques that we tend to get as researchers from public members is when there isn't much going on with the research, and public members can feel really left out, they assume that we know more than they do. And so it's really important to keep that communication going, even when there isn't very much to report. But finally is to have sensitivity to collaborators' needs. This is possibly one of the most important practical considerations, in my opinion, because it's important to show an awareness of public collaborators' individual access needs, as these can sometimes be quite complex and tailored, especially if you think about the landscape that we are collaborating with public collaborators from. Often it's surrounding health or caring responsibilities, meaning that people might not be in the greatest of health or might have some particularly complex access needs. So making specific arrangements for individual members, for example, using paper print-offs or certain fonts in particular colors for those with visual needs, ensures that everybody is able to contribute in a way that's most comfortable for them. Sometimes this can be really tailored, even going so far as to phone people before Zoom meetings take place so that we can give them detailed instructions on how to log on. But sometimes this can also just mean printing off stuff in a particular color so that people with potentially dyslexia or vision difficulties will be able to contribute to the research just as much as people who don't have those access needs. But that pretty much covers everything under the practical considerations, and I believe we have an activity coming up. So I will hand you back over to Georgie.
Thank you, Lauren. So this is the final activity of the day today. It's quite a chunky one, so we're going to dedicate quite a little bit of time of it, really the rest of the sessions. So we really want to make sure that the kind of things we talk about today, you can actually use them on your own projects. So with that in mind, we would like you to go into breakout rooms and actually think about how would you do patient and public involvement in your project. So for example, who would you like to involve in your project in terms of people's lived experience? How would you actually invite these people to be involved? So would you want to connect to existing networks that I mentioned before, so like involvement groups that already exist and approaching community groups, or even utilising your own contacts? What would you actually like to gain from patient public involvement? So in terms of where would you like to bring them in? Could it be at the start when you're actually talking about your research idea? Could it be in data collection? Could it be interpreting some early findings? And then lastly, what methods of involvement would you actually use? So would you like some virtual meetings? Would you like informal drop-in involvement activities? Or would you like to employ more in-person techniques? So I'm going to stop sharing my screen for a moment. So the plan is we'll put you into breakout rooms for 15 minutes. And in your groups, we'd like you to pick one of your projects and then focus on that for the remaining breakout session. And again, I would like you to consider these key questions and then report back to the wider group after we kind of exit the rooms. So when you report back, what we'd like to have is a 2-minute pitch. For 1 minute, just giving us a very brief overview of what your project is, and then another minute just describing what patient public involvement might look like in your project. So with that in mind, does anyone have any questions before we go into these breakout rooms? In terms of that activity, does everyone understand?
I was just going to flag up, Georgia, actually. So just to point out for everyone, that we're doing it this way because obviously we haven't shared the full details yet, but when you put in your project pitch ideas, your pitch submissions in a couple months' time, you're going to put together a 2 to 2.5 minute video that basically pitches your idea for your project. Within that, we would want you to be talking about patient involvement and how you're planning to do that, or kind of a very good reason why you wouldn't. So this is a nice practice for you to be able to try talking about that and thinking about that for your project ideas. So I know some of you have got ideas that are a bit more fully formed, some of you haven't quite got there yet. So I'd advise you just to have a quick chat in your groups about, you know, sort of ideas, and then just go with one of them, and then use that as a kind of rehearsal platform really for this.
Great, thank you, Dan. On that note then, I'll break everyone into the little rooms. And again, me, Lauren and Leon will be floating around. If you have any questions at all, then please feel free to ask us. And we'll also put all the questions that we just showed on the screen in the chat. So you should be able to view it as you go through, so you have something to kind of reference. That should be everyone back, I think. It's looking good. So hopefully that session was quite helpful in terms of letting you think a little bit more about your projects and how to actually practically incorporate patient public involvement in. I think it's always helpful to have those actual real lifetime conversations. But I realise we've only got 9 minutes left, which is absolutely flown by again. So I think for this bit, rather than every group feeding back, I think we should use Dan's lucky wheel again to pick on a group. Also because I just love that wheel generally, so I think I want to see it again.
No worries. I shall bring up the wheel. Let's. They love it when I do this. So, Wheel of Dread, I think they probably called it.
No, we've lovingly dubbed it the Dan wheel. So.
Yes. Same thing. Oh my goodness, that was close. It's BBC Micro, just by a hair's whisker.
Great. Oh, I just want to note as well that I know some of the groups, they hadn't had an idea formed yet. So if that happens to be any of your groups that's picked on today, then please feel free to tell us, and you might want to give us some general reflections about what you need to consider whilst involving people, rather than actually talk about the project. That being said, if you have actually got a project, please give us your 2-minute pitch, giving us an overview of the project itself, and then a minute talking about the patient public involvement. So do we have any takers from the group?
There was only a couple of us in the group, but I work in a trust. Pete works in like CCGs, but we're not involved in any way, to be honest, where it does actually involve the patient public, which we were saying it did seem a bit odd when we started actually thinking about some of the work that we do. We just don't involve them at all. Not at the moment. Not the side that we do, where we're just basically analysing how many people have attended clinics and things like that. But like I said, not even for DNA rates, we don't investigate it and that kind of thing. So we don't actually have a project as such to pitch.
Fine.
Right.
Can I just chip in? Sorry, because this came up in a few of the groups actually, and it might be worth just so. Something that's probably worth flagging up is that with HSMA, most of you, we have a varied cohort, but typically a lot of you work in capacities where you are not anywhere near being public facing in the work that you're doing. You are, doing sort of core analytical stuff, and sometimes you don't even see what happens with the stuff you've done within your own organization, let alone speaking to the masses. One thing to remember with HSMA is it's basically a way in which we don't just show you sort of data science and modeling methods and say now do this stuff. It's a way for you to take on an applied, not just take on, but to project manage an applied research project that has a real world impact for real people, and that could be quite different from the kind of stuff that you're doing, and so it is kind of one of those things where it is a little bit different from how you conventionally work, but it is a really important thing to be thinking about. And I gave the example to one of the groups, but it's probably worth sharing one of the previous HSMA projects, which I mentioned before, around the vaccination modelling work that was done. a couple of years ago in an HSMA project. They set up this fantastic model to work out how to set up their vaccination clinics at the start of the vaccinations being offered, and everything looked great. But remember, at the very start, the first people getting those vaccines were extremely elderly, extremely vulnerable people who were first being offered that stuff. People who had generally been severely locked down and isolated as well, and they hadn't accounted for. In some ways, they planned it as come in, sit down, jab, right, off you go, come in, sit down, jab. They hadn't thought about these are people who are extremely elderly. They hadn't thought about the fact that they will come in, they're going to need to take some time to sit down and take their coat off and take their scarf off and remove their jumper, and they're going to have mobility issues. The fact that they hadn't, in some cases, seen another human being for 12 months or spoken to another human being, and suddenly, having been so isolated, coming into contact with people, they wanted to talk because these people have been incredibly isolated, and all of that stuff that you could not get just from building from looking at the numbers and looking at your resources and looking at your pathway, but actually by seeing what real people are doing and talking to real people and getting that sense about what's actually happening and thinking about the real sort of human considerations in that system was so important. And so thinking about things like that hopefully gives you a sort of a trigger to why this is so important, to be able to go out and involve the public in the stuff that you're doing, that you're not just you're going to be creating some hopefully fantastic models and tools and AI techniques that will hopefully have a huge impact on people, but those people have a right to have a say in that. And we had an example years ago of a cancer project, which I'll talk about on Thursday in the showcase, where it transpired that, and they didn't even know this, that the patients were being told they had a very aggressive form of bladder cancer over the phone. They didn't even know that was happening. And that's the kind of thing that you think, if only there was a patient representative in this room saying, yeah, you make this more efficient, of course, but think about what this means to me as a human being, hearing that kind of information. So hopefully this is giving you a sort of sense of, so this is going to be outside of your comfort zone a little bit and a little bit different to what you're doing, but hopefully this is sort of indicating why it's so important. And a lot of times sort of patient councils and patient groups available within your organizations that can help. And I think George is going to sort of flag up some resources that PennARC offer as well. So I just wanted to flag that up because I heard that in a number of the groups. I just wanted to sort of flag up that you're not alone in I wouldn't expect many of you to have done this kind of thing before, but it is something that is important if you're doing real world applied research, I think.
Yeah, that's really, really helpful. Thank you, Dan. I think we've only got 2 minutes left, so I'll just reshare my screen with you just so I can go about the next stages in terms of patient public involvement if you want some extra support. I just want to say as well, it's a real shame that we didn't have enough time to go around to everyone's individual projects and talk about them, but I'll share all our contact details. So if you want to have a conversation about it at a later date, give me an email. I'll be happy to organise a one-to-one meeting if you would actually find it helpful. Let me just reshare my screen. So I just want to pinpoint these 2 different things that we offer. So I've kind of talked about this briefly earlier in the presentation, but we offer these things called a PPI cafe. And essentially you book onto these 40-minute slots. We have 5 minutes where you pitch your idea to the members of the Peninsula Public Engagement Group, so PENPEG. It's very much an informal conversation, just talking about what you what research idea you might have, and then PENPEG can then give you feedback. They might tell you where you can improve, what you might want to consider, or even give you a little advice about the patient public involvement itself. But alongside this, we also offer PennARC advice clinics. So these kind of have a similar function, but held one-to-one with a PPI team member rather than a public collaborator. So for example, it might be with me or Lauren. So in these, again, the one-to-one, they're more to talk about any methodological concerns. So for example, in one of the other groups today, we spoke about funding for PPIE. So those type of clinics would be very helpful to talk about that and the kind of underpinnings more. So again, I just want to say thank you for everyone for joining, but also give you our email addresses. So if you have anything you want to talk about after the session, again, feel free to email me or Lauren or even the wider PPI team, and then we can support you if you have any questions at all. I just want to say also, everything we've spoken about today, we're going to put together an information pack to send to you. And hopefully this will be a form of support as you're thinking about your projects. But also we'll summarize everything we've spoken about, and we'll also have a copy of the slides and any resources we've spoken about today. So on that note, I thought I'd share my screen, but I think we've just hit bang on 1:30. So again, thank you so much for everyone for joining us today and actually contributing to all the different breakout rooms. I know there's a lot of activities we planned in, so I'm assuming everyone's a little bit drained, but nevertheless, really nice to see so many people come and join us and actually talk about the importance of patient public involvement, which you don't get really a big opportunity to do. So it was lovely, and thank you for Dan as well for hosting us today.
Not at all. Thank you to you, Georgia, and to Lauren and to Leon for giving your time in not only to today to come along and talk to us about this, but I found it hugely fascinating as a researcher just to hear about some of this stuff. But also, you know, putting together such a fantastic session and all the time you've clearly put into doing that. So thank you very much. I think it's going to be hugely important going forward for you know, essentially our HSMA program. We're going to this year, there's going to be 20 research projects taken forward, so this is a huge opportunity, I think, to really get patient voices heard in so many of these projects, and making sure that really, as Georgia sort of mentioned a number of times today, getting it right in from the off, and making sure that's an integral part of the projects going forward. So my thanks to the three of you for coming along today and delivering a fantastic session that hopefully has spurred a lot of thoughts and ideas amongst our cohort. So thank you very much. And thank you to everyone for coming along today, and we will see you next week. You'll be delighted to know that Elliot is going to start teaching from next week, so you're going to mainly have Elliot. I've still got a few more sessions creeping in, but Elliot's going to, what are you doing next week, Elliot? Is it geographic modelling?
It is geographic modelling indeed. So something a little bit different to what we've done previously, but we'll be coding again. And I've got a few things where we'll be doing some code alongs and then some group exercises. I've kind of real life case studies. And spoiler alert, I get to, you know, for those who came to the recap and revision sessions, they'll know I'm a bit of an aviation geek. And so some of the exercises will be based around airport locations, just to make it a bit different to health or police or social care. So hopefully it's going to be enjoyable, and it may give you some ideas for your projects, which is, you know, the main thing.
Fantastic. Yes, there's certainly, I've seen Elliot stuff, there's a lot of aviation stuff going forward. So you're gonna enjoy that. But it's yeah, fantastic, and some great stuff. So geographic modeling, yeah, absolutely, really good, interesting stuff to look at next week. Brilliant. We'll try and get this recording up in the next couple of days, and I will put out information. I haven't forgotten about the Python assessment and the project pitches. That will happen hopefully in the next few days. I'll put out some information about that. Please don't worry about the Python assessment. I made Elliot take it and he said he enjoyed it. So if you don't enjoy it, you can write to Elliot and say, I did not enjoy this Python test. But we have tried. I promise it is made to be as fun as possible in the context of it is a test. But you know, you can only go so far, but hopefully it's good fun. Brilliant. Thanks everyone. Thanks for coming along today, and look forward to seeing you on hopefully some of you on Thursday. Don't forget, I'll be talking, we've got a showcase session on Thursday. I'll be talking about that bladder cancer project for those who are interested in the lunchtime showcase. Otherwise, I'll see you next week. Thanks everyone.
Thanks all. Bye.
Thank you.
Thank you. Bye.
Thanks. Bye.
Thank you very much.